Hold just a minute, everyone. I'm trying to get rid of something, and no, there it is. Jeez. All right, I think I got it. All right, students. This is Dr. Weaver, and I am going to be speaking to you about assessment and care of patients with problems of fluid and electrolyte balance. And this information can be found in chapter 11. I'm trying to decide how far I want to do a voiceover on this particular a PowerPoint presentation. I think it is roughly about 20 something slides that I will have to do a voiceover or talk about. And so I may just do half of it, and then you guys can just read the rest of my notes for the other half. Kind of depends on how I feel. Because I have provided voiceovers on two of the other topics. There's three different topics. There's fluid and electrolytes, acid-base balance, and the other one is infusion therapy, I believe. So the only one that I did not do a voiceover on is fluid and electrolytes. So I may just do half, and you can get the rest by reading my notes and my PowerPoints. But you know, I may feel well enough to go the distance. Not that I'm sick, but this is quite a laborious task to do. So anyway, might as well go ahead and start. So fluid and electrolytes is the kind of care that you will be providing for your patients quite a bit, especially in the acute care setting, in many settings, but especially the acute care setting. And having knowledge of fluid and electrolytes will help you to safely provide the care that your patients need to keep them safe. Now, optimal body function does depend on maintaining fluid and electrolyte balance in each body's fluid space, or we call it compartment, because we have fluids in a variety of spaces, be that intracellular inside the cell. We have fluids on the outside of the cells, and we also have fluids in our interstitial interstitial compartment or space as well. And so keeping this balance within normal ranges is part of the homeostasis process. Now, because the range of normal is very narrow, the body has many control actions or what we call homeostatic mechanisms to prevent any dangerous changes or shifts. Just like when we were talking earlier about acid-base balance, there are mechanisms in place to keep our acids and bases in check, to make sure we have no extreme shifts in acidosis or in that direction or alkalosis, but keeping it within that slightly alkalotic range, if you will, 7.35 to 7.45. Well, our fluid and electrolytes also have a narrow range as well. And so This is why when you are in the acute care setting or other settings where you are monitoring your patient's fluid status, the electrolyte status, um, your assessments with these patients rather is so important because as you collect this information, we have to know when to report critical information. So for example, if a potassium level is, let's say, 2.5, then you want to make sure you report that. If somebody's showing signs and symptoms of fluid volume access, you want to report that because these types of patients, they can develop what we call pulmonary edema and other problems that goes along with that. Now, water delivers dissolved nutrients, water that is within our vascular space. It delivers dissolved nutrients and electrolytes to all organs and tissues and cells. So it essentially acts as a transport system, right? Kind of think of water being a truck that has all sorts of supplies, and it uses, of course, our highways and streetways to bring certain products to different areas of need, like to our community stores and such as that. And so the streets would be like our veins and arteries and whatnot, particularly our arteries in this case, because arteries actually delivers the good stuff to our organs, tissues, and as well as our cells. So anyway, this water in our vascular system, or also within our blood, it helps to deliver these essential items in order for us to remain healthy. Now, in health, the volume of water in fluid compartments remain, again, within normal range. Although water does move constantly between compartments, all right? It's more of a kind of a fluid kind of a situation where fluids are constantly moving instead of a static situation, if you will. Now, changes in either the amount of water or the amount of electrolytes in body fluids can reduce the function of all cells, tissues, and organs. So when you have these shifts or changes in our electrolytes, the cells, tissues, and organs will not function very well. So again, it does require a certain amount of fluids, a certain amount of electrolytes for optimal functioning. Now, body fluids are composed of water and particles dissolved or suspended in water. Now, the water portion is what we call a solvent, right? So the water we speak of, or the fluids, is called the solvent. Solutes are the particles dissolved or suspended in the water. Solutes vary in type and also amount from one fluid space to another. Now, when solutes express an overall electrical charge, they're known as electrolytes. So when you think about your potassium or K plus, or sodium, which is Na plus, or chloride, which is Cl minus, or magnesium, which is Mg plus plus, those pluses and negatives are charges, and those are called electrolytes. I mean, you do have dissolved nutrients as well, but those are not called electrolytes because they don't carry that overall electrical charge. And so we look at our BMP to inform us of our patient's electrolyte status. And this is our priority concept in this chapter, fluid and electrolytes. Of course, I mean, it stands to reason that this would be our priority concept. This is what the chapter is all about. And the interrelated concept, the exemplar in this chapter would be dehydration, but the interrelated concept in this chapter would be perfusion, because without perfusion, then if we don't have adequate perfusion, then we cannot have those solutes, the nutrients, electrolytes, and so forth. It cannot be delivered to our organs, tissues, and our cells as well. So think about these concepts as we continue this discussion. Now, remember I talked about where fluids can be, the different compartments where fluids can be found. And as you can see here, it is found in the extracellular fluid. This means outside the cell. It is also located in the intracellular fluid, also in the interstitial fluid, and also transcellular fluids as well. And of course, as you can read here, proper functioning of all body systems requires fluid and electrolyte balance. All right, and that fluid is shifting between all these different compartments. Wherever there's need, it moves there, and wherever there's not a need, then of course it remains more or less a constant or within the normal range, if you will. Now, optimal body function depends on maintaining fluid and electrolyte balance in each body fluid space or compartment. Keeping this this balance within normal ranges is again a part of the homeostasis process. All right. Now, because the normal range is so narrow, the body has many again control mechanisms to stop any major shifts. Now, water makes up about 55 to 60% of total weight for younger adults, and only, well, I mean, 50 to 55% of total weight for older adults. And this is significant because it tells us that older adults are more prone to dehydration as compared to their counterparts, younger adults. Now, this water is divided into two main compartments or spaces. The fluid outside the cells, again, that would be extracellular or ECF, and the fluid inside the cells would be your intracellular fluid or ICF. Now, the extracellular fluid space is about 1/3 or about 15 liters of the total body water. All right, so that's 1/3. The ECF includes interstitial fluid. So again, everything outside the cell. So we talk about the interstitial fluid or fluid between cells, or what we call third space. This is where we see most of our edema or swelling in that particular compartment. There's also blood, lymph, bone, and connective tissue, water, and the transcellular fluids as well. Now, most of the fluids is found, total body water is found inside the cell or intracellular fluid, about 2/3 or 25 liters. So a whole lot more. I don't know why I kind of, I actually duplicated the same information, and I don't know why I did that. I will say that I'm kind of rushing through getting this together because I didn't have a whole lot of time. So, you know, just trying to do the best I can with it. Now, so we are going to, so today I spoke to you guys about most of you who probably did not have chemistry, all right? And many of the concepts we will be discussing in this chapter, at least initially, will be sort of heavy into chemistry, all right? For example, there's different concepts such as filtration, diffusion, and osmosis. And there's some of this you probably, I'm sure you've heard of already. But as we talk about these chemical processes, all right, what I will do eventually, we'll talk about the chemical process, but then we'll talk also about how these processes relate to us clinically, right? How does it relate to what we do as nurses? So we'll get to that part. So just bear with me as we go through some brief explanations of these different processes. All right. Now, three processes control fluid and electrolytes, electrolyte balance. And this is why talking about these processes, although along the lines of chemistry, is so important because human beings have fluid and electrolyte um, um, issues, or this is what is a part of our makeup, fluid and electrolytes. And so we have to learn these processes because this is how fluids and electrolytes move in different spaces, if you will. And this is what this is all about, really. Now, again, the process, these processes, filtration, diffusion, and osmosis, they determine whether fluids and particles move across cell membranes. Right? Remember, it's moving in different compartments or spaces, fluid spaces. All right. Now, filtration would be the first process that we will discuss. Filtration is the movement of fluid or water through a cell or through a blood vessel membrane because of water pressure. You know, when this water pressure gets too high, it creates a pressure called hydrostatic pressure. All right. Now, again, so filtration is the movement of this fluid through the cell or blood vessel membranes because water pressure differences on both sides of the membrane, right? And you know how if the pressure is higher on one side, typically it moves to the pressure where there's less, or where the pressure is less, or from higher to lower. Now, this pressure is actually caused by water volume that is pressing against confined membranes. So, for example, in heart failure, when on the left side of the heart, when blood is backing up because the heart is failing, and this blood, it goes back into the vascular system of the lungs. And when there's this increasing volume of blood in that small space, all right, it is pressing against those membranes, if you will. Now, this is a water pushing kind of pressure because it forces water outward from a confined space through a membrane. And so in the example of heart failure, you've all heard of the term pulmonary edema. And so this is when fluids is leaking out of the vascular space, which is that confined space, and leaking into the lung tissues, all right? Because that confined space has a certain capacity, and it has to go somewhere. And so then it just crosses the vascular the membrane and into the lung tissues. And this is why when you take a stethoscope and you auscultate breath sounds on someone in this condition, you hear crackles, and that is the fluids within the lungs. So that's kind of a clinical example of how this pertains to nursing, if you will. I kind of brought it forth a little sooner, but there's another example I think I'm going to get to where it talks about with heart failure, especially right-sided heart failure, blood backs up on the right side of the heart and into the periphery. And this is why when you look at someone's lower extremities or the lower limbs, you see all this swelling, because remember that blood is backing up into this confined vascular space, and it only has a certain capacity, and so it begins to leak out into the interstitial fluid space, causing edema. All right. Now, the amount or volume of water in any body fluid space determines the hydrostatic pressure of that space. So the more volume, the higher the hydrostatic pressure. Now, blood, which is thicker than water or more viscous, is confined within blood vessels. Now, blood does have a hydrostatic pressure because of its weight and volume, and also from pressure in the arteries generated by the pumping action of the heart. But, just keep in mind, when it becomes, when that confined space in the arteries becomes overwhelmed, then this fluid is going to eventually leak out. Now, water molecules in a confined space constantly press outward against the membranes, creating this hydrostatic pressure known as water pressure. Now, this is a water pushing pressure because it forces water outward from this confined space and through the membranes, as I mentioned before. Now, blood pressure is an example of a hydrostatic filtering force. It moves whole blood from the heart, and then it moves it to our capillaries, where filtration can occur to exchange water, nutrients, and waste products between the blood and the tissues, right? So what that is saying is, when blood is pushed out from the left ventricle into the systemic circulation, and so it is traveling in our arteries in order to make its way to our capillaries. Because remember that oxygenated blood that also contains nutrients and minerals and so forth, it has to get to our tissues and organs, our vital organs and tissues and whatnot. All right. So it does that good blood, if you will, it doesn't just go from or travel from the arteries and then directly into the tissues and organs, but it has to go through the capillaries first. All right. And then from the capillaries into our interstitial space and our organs and tissues, if you will. All right. And so this is that filtration process that is taking place, wherein when these nutrients and whatnot, oxygen and so forth, are pushed or exchanged in our capillaries into these organs and tissues, it is in order to receive rather water, nutrients, and waste products. Then this is what has to happen at that level for this to occur. It must go through the capillaries is what I'm actually trying to get across to you all. Capillaries are kind of that intermediary between the arteries, arterioles, or whatnot, and our organs and tissues. All right, it just has to cross over the capillaries. And then, of course, waste products comes from our organs and tissues, back into the capillary system and then into our veins in order to, because it becomes waste and it is carried away and back towards the heart. All right. And for example, CO2 would be something that is carried back to the heart in order to exchange it for oxygen. So that's sort of how that works. Now, the hydrostatic pressure differences between the capillary blood and the interstitial fluid, fluid in the tissue space, determines whether water leaves the blood vessels and enters the tissue spaces. So in other words, what that is saying, the hydrostatic pressure that is in the capillaries have to be higher in order for it to push those nutrients, water, and so forth into the tissue spaces. All right, it has to be higher in the capillaries in order for that to take place. And this is all chemistry, all right? Now, capillary membranes are only about one cell layer thick, so it's not very thick. So it's actually a thin wall. to hold blood in the capillaries. Now, large spaces or pores in the capillary membrane help water filter freely when the hydrostatic pressure gradient is present. So it has to be a high hydrostatic pressure in order to push it into the tissue, into our tissues. Now, clinical significance, remember the edema I was talking about. Again, so how does this pertain to us as nurses? The clinical application, if you will. So I talked to you about edema, all right? This is excess tissue fluid. So edema forms with changes in hydrostatic pressure differences between the blood and the interstitial fluid, such as in right-sided heart failure. In this condition, the volume of blood in the right side of the heart increases because the right ventricle is too weak to pump blood into the lungs, the lungs blood vessels. All right, so the ventricles are just too weak. It just can't pump it forward, and so it begins to back up. So as blood backs up into the venous and capillary systems, the capillary hydrostatic pressure rises until it is higher than the pressure in the interstitial space. And of course, the excess filtration from the capillaries into the interstitial space then forms what we call visible edema, because all that pressure is so high in that extra pressure from all that volume that is backing up. It is so high in the capillaries, it pushes it into the interstitial space, and this is when we assess edema in our patients. Remember that vascular space can only withstand so much volume, and so it has to go somewhere, and the interstitial space is that space of that area. All right. Now, hold just a moment. All right. So the next process, so we just talked about filtration and in terms of how fluid moves from one compartment to another. So now we will discuss diffusion, which is the second process that we will talk about and how it relates to the human body. So with diffusion is the movement of particles or solutes. All right. Now filtration is the movement of water, whereas the opposite of that would be diffusion, which moves particles instead. And these particles or solute are moved across what we call a permeable membrane from an area of higher particle concentration to an area of lower particle concentration, which is going down a concentration gradient from high to low, right? Now, when we talk about permeable, the membrane, in other words, the membrane is permissive. It's allowing, let's say a cell membrane, it's allowing certain particles through. because we also talk about impermeable, which means that it doesn't allow um, anything through. And then we also talk about semi-permeable, meaning it's selective. It allows only certain particles through. All right. So in this case, diffusion is the movement of these particles across a permeable membrane, and the concentration of those solutes has to be pretty high, and then in order for it to cross over, all right, into the next compartment, if you will. Now, particles in a fluid have random movement from the vibration of atoms in the nucleus. All right. So random movement allows particles to bump into each other in a confined fluid space. Say, for example, in the vascular space. So each collision increases the speed of particle movement. Now that's all chemistry and everything, and so don't get too caught up in all that. But good for you to still know, because when you do finally take chemistry, then at least you have this exposure. Now, as a result of the collisions, molecules in a solution spread out evenly through the available space. Now, they move from an area of higher molecule concentration to an area of lower concentration until an equal concentration amount is present in all areas. So it's just trying to establish equilibrium. You can't have this high concentration on one side and low on the other side. Remember, it has to, each compartment, there has to be a narrow range of fluid and electrolytes. And so this process will allow these solutes to move to areas of high concentration to lower until we get that even kind of concentration. And hopefully that makes sense. Now, spaces with many particles have more collisions, of course, because it's more particles in that area. And the particles move faster than spaces with fewer particles. All right. So in essence, if you got a side of that membrane that has a high concentration of particles, they bump into each other a whole lot often, and it's very fast and whatnot, in terms of how they move, as opposed to the other side that has less particles. Then they're barely hitting each other, and their movement is not as fast. So, so then the question becomes, what is the clinical application here? How does it pertain to what we do as nurses? So diffusion, this process of diffusion, it transports most electrolytes and other particles through cell membranes. All right, that area of high concentration to low concentration, but it has to cross that cell membrane, right? And that cell membrane has to be permeable to some extent or other. Now, cell membranes, unlike capillary membranes, are quite selective for which particles can diffuse. So it doesn't accept everything, right? They permit diffusion of some particles, but not others. And I mentioned that earlier. Some particles cannot move across a cell membrane, even when there's a steep downhill gradient exists, because the membrane is what we call impermeable or closed to that particular particle. All right, so some particles can cross over the cell membrane, and some cannot. If they cannot, they're impermeable. All right, now impermeability, right? The ability to select what comes over, or special transport systems cause differences in the amount of specific particles from one fluid space to another. Sometimes we have these special transport systems. For example, usually fluid outside the cell or extracellular fluid has 10 times more sodium than fluid inside the cell intracellular fluid. Now, this extreme difference is caused by cell membrane impermeability to sodium, right? It's only going to allow so much sodium inside the cell. And also by these special sodium pumps that move any extra sodium present inside the cell out of the cell, and it goes against this uphill um, against the concentration gradient and back into the extracellular fluid. So if there's an excessive amount of sodium inside the cell, there are these special pumps that helps to push it up this gradient. Because remember, most solutes, or even fluids for that matter, it's easier for them to move from a high gradient down to the low. But in this case, since the membrane is so selective, it requires this special pump to push the sodium back out, this excessive amount of sodium back out of the cells. And in this case, back into the extracellular space, which is where most of our sodium is found. All right, again, you have to maintain a certain amount of sodium extracellularly as well as intracellularly. It has to be a certain range, all right, for things to work right. Now, for some particles, diffusion cannot occur without help, even down a steep concentration gradient because of selective membrane permeability. So some particles just cannot cross over into cells on its own. And one great example of that, which I'm going to, let me highlight that one so you'll know this is a good example. One example is glucose. Even though the amount of glucose may be much higher in the extracellular fluid space than the intracellular fluid space, which would create a steep gradient for glucose, glucose cannot just readily cross some cell membranes without help of insulin. So with insulin being like a key, it binds to the insulin receptors. They're receptors that are located on the cell membrane. And so this key or insulin goes into goes into or is placed into kind of like a lock. So the lock would be the insulin receptors on the cell membrane. And so this key goes into this lock and it turns and it opens the door, right? Which then makes the membrane much more permeable to glucose. In other words, this is how glucose is allowed access inside the cell. So it requires insulin, the key, in order to access that lock or the receptor on the cell to open it up, open up the door, and then, glucose can now go inside of the cell to be used by the cells for fuel or energy, if you will. All right. Then glucose can cross the cell membrane down its concentration gradient into the cell. That's the only way you'll get glucose inside the cell. That's what happens in diabetes. The reason the blood sugar is so high is because the glucose is on the outside of the cell, but it's supposed to be transported inside the cell. So when a patient has, let's say, type 1 diabetes, which means they're not producing any insulin, then the glucose remains outside the cell. All right. And of course, your body has to use something for fuel, so it'll begin to break down or consume fat. And the byproduct of consuming fat is fatty acids. And this is why they go into diabetic ketoacidosis, because it's actually consuming fat instead of glucose. And so that's a little tidbit for you. So when we do go into diabetes, especially that particular complication, which we won't delve too much into because that's taught in term or multi-organ systems. Now, diffusion across a cell membrane that requires a membrane altering system, such as insulin, is called facilitated diffusion. All right. And this type of movement is still a form of diffusion because it does not require extra energy. All right. And so now we're looking at a combination of both osmosis and filtration. This is particularly the osmosis will be the third process that we will discuss. But you can't discuss osmosis without filtration, obviously. Now, osmosis is the movement of, now we're back to water, a movement of water only through selectively permeable membrane. And so it is said to be semi-permeable. All right. So we are talking about water, just like that. Let's see. Filtration talks about water, and also osmosis talks about water as well. All right. Now, for osmosis to occur, a membrane must separate two fluid spaces. And one space must have particles that cannot move through the membrane. So you have this partition, all right? There has to be a partition that separates two different spaces, right? And again, one of those spaces has to have a number of particles that cannot cross over the membrane. And so the membrane would be impermeable to these particles. Now, a concentration gradient of this particle must also exist. Now, because the membrane is impermeable to these particles, they cannot cross the membrane, but water molecules can. All right, and this is how we're going to get this equilibrium at some point. Water is going to help us out. All right. Now, for the fluid spaces to have equal concentrations of particles, the water molecules move down their concentration gradient from the side with a higher concentration of water molecules and a lower concentration of particles along with a greater hydrostatic pressure to the side with a lower concentration of water molecules. So concentration of a higher concentration of water molecules, that higher concentration down that concentration gradient to the lower concentration of water molecules, and a higher concentration of particles along, again, with the lower hydrostatic pressure. Again, don't get too caught up in a lot of these processes, if you will. So, because we'll talk about the clinical significance. Now, this movement continues until both spaces contain the same proportion of particles to water. All right. So there's a certain amount of particles to water. Now, before this took place, you had a low amount of, or rather, a low amount of water on one side to a certain amount of particles, whereas though on the other side you have this high amount of water to a certain amount of particles. And so we need to try to even that out. It's not even, right? And so in order to keep these ranges in check, osmosis will allow water molecules to go to that area of lower water or fluids, if you will, in order to even things out. So water moves by osmosis down its hydrostatic pressure gradient from the dilute fluid, because remember it's dilute on one side, to the more concentrated fluid until a concentration equilibrium is occurs. So one side is more dilute because it's more water to solutes, compared to the other side, which is more concentrated, right? And so in order to even those out, to have the same proportion of water to solutes on one side as compared to the other, then you have to have this process of osmosis to occur to make that happen. Again, because we're trying to stay within certain ranges, whatever compartment we're in, as it relates to fluids and electrolytes. Now, at this point, the concentrations of particles in fluid spaces on both sides of the membrane are now equal. even though the total amount of particles and volumes of water are different. All right. Now, the concentration equilibrium occurs by movement of water molecules rather than the movement of solute particles. It's all about the water in this regard. Now, particle concentration in the body is the major factor that determines whether and how fast osmosis and diffusion can occur. All right. So there's a few concepts that we're going to discuss, and what it basically relates to is whether or not our blood is concentrated or more dilute or is normal. So in other words, equal proportion of fluid and particles. So in other words, like hypertonic, which would be more concentrated, versus hypotonic, which would be more dilute. And then you have isotonic, which would be more equal. It's neither hyper or hypo, but it's just right in terms of fluids and particles. Now, there's a term called osmolarity. Osmolarity is the number of millimoles in a liter of solution. And then we talk about osmolality is the number of millimoles in a kilogram of solution. And so what we're trying to get to here is we're talking about essentially whether or not our blood plasma is, again, concentrated or not. So the normal osmolarity, when you look at your lab values, the normal value for plasma and other body fluids is supposed to be between the range of 270 to about 300. The closer to 270, the more dilute our blood is, our plasma is. The closer to 300, the more concentrated. And actually, within that range, you're more isotonic. But when you go to one extreme or another, it will determine if you're hypertonic or hypotonic, meaning more dilute when we talk about hypotonic. Now, the body functions best when the osmolarity of all body fluid spaces is closer to 300, all right, which was still normal. When all fluids have this particle concentration, the fluids are what we call isotonic, all right, or normal tonic to each other, all right. So when all fluids have this particle concentration of about roughly 300, it's more equal. And that's what that's saying. Now, fluids with osmolarities greater than 300 are known as hypertonic compared to the isotonic fluids. So we're always making a comparison to the isotonic. All right. These fluids have greater osmotic pressure than does the isotonic fluids, and tend to pull water from the isotonic fluid space into the hypertonic fluid space until an osmotic balance occurs. So in essence, if fluids is more hypertonic, if it's more concentrated, it is going to pull fluids out of a space that is either equal, has equal concentrations or less. All right. The hypertonic solution has a stronger pulling effect. Now there are there are times when we want, for example, if we have cells, this is kind of the clinical significance. You have a patient who has a brain injury and they have cerebral swelling. In other words, the cells of the brain have a lot of fluid within the cells. And sometimes we would give these patients a hypertonic solution because when you infuse hypertonic solution into the extracellular space, the concentration is so high, it will pull that extra fluid from the brain cells, all right, decreasing the edema in brain cells because, you know, we don't want brain cells to be increased. We don't want swelling on the brain because it damages, areas, vital areas in the brain. And so one of the fluids that we might use is mannitol. Mannitol is an extreme hypertonic solution, and it has this tendency of pulling fluid from cells. All right. So the IV fluids are infusing in the extracellular space, and it pulls fluids from the intracellular space, is what I'm saying. So, if a hypertonic solution, IV or infused into a patient with a normal ECF osmolarity, and by the way, an example of an IV solution that is hypertonic is 3% or 5% saline. That's a pretty high concentration of saline or salt or sodium. So if this IV solution was infused, as I mentioned, in the extracellular space of a normal ECF osmolarity, all right, the infusing fluid would make the adult's blood more hypertonic, because that's what these fluids are. When you infuse them into the extracellular fluid space, it causes that those fluids to be hypertonic. It's more concentrated. All right. Now, to balance this situation, the interstitial fluid would be pulled. You know, you have this fluid into the interstitial space. So the interstitial fluid would be pulled into the circulation in an attempt to dilute the blood osmolarity back to normal. So in essence, you know how you have the fluids within the interstitial space? If the osmolarity becomes highly concentrated because of the hypertonic solution, remember, we're looking for equilibrium. We're looking for balance. So the hypertonic solution is so concentrated, it will pull fluid from the interstitial space in order to dilute, because we don't like very concentrated blood. We want it to be a little more dilute. We want it to be between 270 and 300. And so it has to pull to get fluids out of the interstitial space to dilute it more. So as a result, when this happens, the interstitial and the intercellular volumes will shrink. So you have less volume in the interstitial space, and this high concentration of sodium will also pull fluid from the cells as well, and so they will shrink. All right, and the extracellular fluid space or compartment, it will expand in volume, because remember, you're pulling fluids from the cells and from the interstitial space into the vascular space or the extracellular fluid compartment, and so it'll make it, you'll have more plasma volume in that particular space. All right. Now, when you have hypotonic solution, so fluids with osmolarities less than 270 are said to be hypotonic, again, compared to isotonic fluids. All right, so it's less concentrated. Hypo, less concentrated. All right. Now, this hypotonic fluids have lower osmotic pressure than does the isotonic fluids. And water is pulled from the hypotonic fluid space into the isotonic fluid spaces of the interstitial and intracellular fluids. So in other words, fluid would now go inside of the cells, right? And it will also go into the interstitial space as well. because it's a lower hypotonic solution. So as a result, the interstitial and the intracellular fluid volumes would expand, right? So with the hypertonic solution, the intravascular volume space, ECF, will expand. But if the fluid is hypotonic, then the interstitial space, because fluids will be going into the interstitial compartment and also into the intracellular compartment of fluid space, and it will expand it, right? And the plasma volume, that extracellular fluid space will shrink because there will be less fluid in that compartment. And so an example of hypotonic IV solution is 0.45% saline, all right? And let me show you what the cells would look like. So so I just want to show you something here real quickly. All right, see if I can pull this over, show you what I'm talking about. Uh-oh. Oh, here I go. So, and now these are just the cells, right? So let's say if this is a normal cell, right? And I give someone hypotonic solutions. And just imagine this being the extracellular fluid space outside the cell, and this is the intracellular fluid space. So what would happen with hypotonic solution, because it is hypotonic or contains less concentration, let's see if I can draw this. Fluid will move inside the cell, right? Causing it to become larger, right? It will swell, the cells will swell. And you guys have probably saw this process before. But in this case, the cell will swell. But then let's say you give a patient a hypertonic solution, right? So what would happen is fluid that is within inside the cells will leave the cells, right? And then the cells will shrivel up or they will shrink because you're pulling fluid out of the cell. And this is what that high concentration of hypertonic solution will do. It will pull fluid out of the cell, causing it to shrink. All right, and so this is the hyper type. Oh, excuse the handwriting. That's the hyper type, and this would be the hypo type of fluids. And so depending on your patient's condition, it will determine which solution your healthcare team will use. All right, so that's what I want to say about that. I just wanted to give you an example. Let me go back and share what I had showed you before. Let me make sure I'm sharing this. All right. So now, when we think about the clinical application, how does this pertain to nursing? Osmosis and filtration act together at the capillary membrane in order to maintain both extracellular fluid and intracellular fluid volumes within their normal ranges. So as I told you, both of these act in concert. They work together. So, for example, well, the third mechanism, or the thirst mechanism is an example of how osmosis helps maintain homeostasis. The feeling of thirst is caused by activation of cells in the brain that respond to changes in ECF osmolarity. So if the osmolarity is very high, let's say 320, then there's some dehydration going on there. And so these cells in the brain, they're so very sensitive to changes in the extracellular fluid space, osmolarity. They're called osmoreceptors. They're very sensitive to that environment. So when an adult loses body water, when an adult loses body water, but most of the particles remain, such as when someone is sweating excessively, the extracellular fluid volume will decrease. The particles remain, but the volume decreases because you're sweating out a lot of the fluids. And its osmolarity would be increased or hypertonic, right? Now, the cells in the thirst center, they will shrink as water moves from the cells and into the hypertonic ECF compartment or space. And that's not what we want, right? We don't want our cells to shrink. Now, the shrinking of these cells triggers an adult awareness of thirst, all right, and increases the urge to drink. And drinking replaces the amount of water that is lost through sweating and dilutes the extracellular fluid osmolarity, returning it to more normal. All right, and so this is why this is important. It causes us to drink fluids to restore that normality, if you will. All right, so hopefully you guys understand these different processes because they do have relevance to us in nursing. All right, so now we will talk about fluid balance, closely linked to and affected by electrolytes, concentrations. Talk about fluid intake, fluid loss as well. And as you can see here, minimum urine amount is needed to excrete toxic waste products, or the minimum, I should say, the minimum urine output needed to excrete these toxic waste products would be between 400 and 600 milliliters per day. So if somebody can void or urinate between this range, then you can get rid of a minimum amount of the toxic waste. And also your book talks about insensible water losses because we lose fluids more than just through, let's say, our urine, but also through skin, through our lungs, and also through stool, because our stools even have a certain amount of fluid as well. Now, fluid balance is closely, again, related to, and it is affected by electrolyte concentration. So what I want you to do is take a look at table 11.1. Table 11.1 lists the normal ranges of the major serum electrolytes. It lists conditions associated with high or low values, all right? And chart 11.1 lists the normal electrolyte values for people who are older than 60 years of age. So take a look at that. You guys really need to know these values because you may have to analyze a question on your HESI, on NCLEX, on my test, where you have to provide some information or produce an answer based on the analysis of that data. Now, age, gender, and amount of fat affect the amount and distribution of body fluids. Remember, older adults have less body fluids. Women would typically have less body fluids, and males would typically have more body fluids because muscles carry more water. Chart 11.2 shows age-related changes in fluid balance. So as far as, in other words, as far as skin is concerned, these patients who are older, there's a loss of elasticity. There's decreased turgor. You know, turgor is when you, for example, you take someone's hand and you pinch up the skin, you tent up the skin, and if it remains, it's because they're dehydrated. Not the best indicator, but we typically use it. Sometimes they do it in the forehead. They'll tent up the skin, and if it takes some time to go back to its normal position, it could indicate dehydration. Older people also have a decrease in oil production. The reason this is important is because the skin becomes, it then becomes an unreliable indicator of fluid status, especially the back of the hand that is more dry and easily damaged skin. So you can't use you can't use the skin to determine fluid status in your older folks. So you have to use other indicators. Urine output being one. Now, another example, kidneys. With older adults, there's decreased glomerular filtration. There's also decreased concentrating capacity of our urinary system. What this does, it results in poor excretion of waste products, increased water loss, and increasing the risk of dehydration. And just make sure you read the rest of that chapter in your readings, or this section in your readings. As I mentioned, women of any age have less total body water, and they're higher risk for dehydration than men of similar size and ages. This difference is because men, again, they have more muscle mass than women, and because women have more body fat. Fat contains less water, and muscles contain more. Right, so your women will have, they're at greater risk. Now, fluid intake is regulated through the thirst drive or mechanism. Fluids into the body as liquids and solid foods, which contain up to 85% water. Also take a look at table 11.2 for routes of fluid ingestion and excretion. So for example, as far as intake, we measure oral fluids, we measure parenteral fluids as well. As far as output, we look at a patient's urine, their emesis, as well as their feces, right? Especially with diarrhea. Now, there's also unmeasurable intake, PO intake, and that is, for example, solid foods, and as well as metabolism. It's you can't really measure it, all right, but it is considered intake. There's also, when we talk about output, we think about perspiration and evaporation through the lungs, those insensible water losses, and you just can't measure it. Kind of have an idea, but you can't really measure it. Now, fluid loss occurs through several routes. The kidney is the most important and the most sensitive water loss route because it is regulated and adjustable. Now, the volume lost through urine elimination daily varies. Depending on the amount of fluid taken in and the body's need to conserve fluids. All right, so if the body really needs the fluids, then you won't void or eliminate as much. So it just depends. Right, and as I mentioned to you, the minimum amount of urine per day needed to excrete the toxic waste products is about 400 to 600. Actually, 400 would be called, what do you call it, oliguria. All right, now this minimum volume is called obligatory urine output. Now, if the 24-hour urine output falls below the obligatory output amount, it means that, or it will result in waste products being retained. And it can cause lethal electrolyte imbalances as well as acidosis and a toxic buildup of nitrogen. So your BUN would be very high. Your creatinine would be very high in these cases. Now, the ability of the kidneys to make either concentrated or very dilute urine helps to maintain fluid balance. The kidneys works with various hormones to maintain fluid balance when the extracellular fluid concentrations, volumes, or pressures change. All right, and we'll talk about some of those hormones. For example, aldosterone being one of them. We'll talk about aldosterone. Now, other normal water loss occurs through the skin, through the lungs, and also the intestinal tract. These are the ways that we lose water. Now, water losses also can result from salivation. Those who, the saliva, in other words. Also drainage from fistulas and drains. All right. So when your patient has a fistula or they have drains, we want to make sure we monitor those for fluid losses, and also GI suction. All right. So we can lose fluids through these routes. This loss is called insensible water loss because no mechanism controls it. Now, in a healthy adult, insensible water loss is about 500 to 1,000 milliliters a day. Now, this loss increases greatly during thyroid crisis, during trauma, burns, especially burns, states of extreme stress, and also fever. Now, patients at risk for excess insensible water loss include those being mechanically ventilated, those with rapid respirations, and those undergoing continuous GI suctioning. I mean, you're losing quite a bit of insensible water. All right. Now, water loss through stool increases greatly with obviously severe diarrhea or excessive fistula drainage. And fistula is a kind of tunneling from, let's say, one space in the body to another, and they drain profusely, right? So if these losses are not balanced by intake, in other words, as we lose these fluids, if we don't balance it by taking in intake of some form, be that IV or by mouth as far as drinking, insensible losses can lead to severe dehydration as well as electrolyte imbalance. So it can be very dangerous. So we have to be aware of these insensible losses. There are those losses that are more measurable, but we always have to think about the immeasurable or the insensible losses, because you more or less can add to, although you can't document it because you don't know what the insensible losses are, but you can have an idea. If a patient loses 2,000 cc's as far as output, then you can probably say it's about 2,500 to 3,000 actual loss. So we have to think about those things, especially if a patient is on a ventilator and they're breathing, the machine is breathing very rapidly or rapidly for the patient, or at an increased rate, I should say. You're losing, you have that vaporation. You're losing a lot of that through breathing. Now, remember I talked about the hormonal regulation of fluid balance. So there are hormones that help to regulate fluid balance as well. Three hormones help control fluid and electrolytes. These are aldosterone, ADH, or antidiuretic. So remember, when you think about antidiuretic, it means against diuresis, in other words, the elimination of fluids, mostly through the urine. So when ADH, when that hormone kicks in, you actually retain fluids. All right, antidiuretic. We give patients diuretics to help them pee, but the ADH hormone prevents diuresis by way of the kidneys. There's also another hormone called natriuretic peptide. All right. Now, aldosterone is secreted by the adrenal cortex, right? That's that region of the cortex outside or that surrounds the medulla. So this aldosterone is secreted by the adrenal cortex whenever our sodium levels in the extracellular fluids space is low. Now, aldosterone prevents both water and sodium losses. When aldosterone is secreted, this hormone acts on the kidney nephrons, triggering them to reabsorb sodium. And of course, water follows. So it reabsorbs sodium as well as water from urine back into the blood. And this action increases the blood osmolarity and blood volume. All right. Because when you don't have as much sodium in your system, your blood will be more dilute. And this process, this aldosterone hormone, will actually make it a little more concentrated or a more increased osmolarity. All right. Now, aldosterone also promotes a kidney potassium excretion. All right. So with these patients, when this process occurs, all right, you have to monitor these patients' potassium levels. So you're looking at those labs. Always look at those labs. So the next hormone that we discuss is the antidiuretic hormone, or vasopressin. It is released from the posterior portion of the pituitary gland in response to changes in blood osmolarity. So when the blood osmolarity changes, say if it becomes too concentrated, then the hormone ADH is going to be released. When you think about the pituitary gland, you have the anterior and the posterior pituitary gland, and we learned we'll delve more into diseases and disorders that affect the pituitary gland later, or rather in adult health 2, 1650, which is also what I teach. So the posterior portion of the pituitary gland deals with oxytocin production, which we're not talking about that, but also ADH. Now, the hypothalamus is also important here. The hypothalamus contains the osmoreceptors that are sensitive to changes in blood osmolarity. So when someone has an increased blood osmolarity, especially an increase in the levels of plasma sodium, it results in a slight shrinkage. It causes the cells to shrink of these cells. It causes these cells in the hypothalamus to shrink, right? Because when there's a lot of sodium, increased sodium in the plasma fluid, it's more hypertonic, all right? And a hypertonic environment, it has a pull. So it pulls fluids from the cells, right, causes them to shrink, and it triggers the release of ADH from the posterior portion of the pituitary gland. Now, ADH acts on kidney nephrons also. Aldosterone does, as well as ADH, making them more permeable to water, right? Because we want water back. Antidiuresis, we want water back to dilute that increased osmolarity of the plasma blood. So as a result, here, more water is reabsorbed by the tubules and returned to the blood, decreasing blood osmolarity by making it more dilute. Now, when blood osmolarity decreases with with low plasma sodium levels, right, the osmoreceptors will then swell slightly because remember that hypotonic environment, and this is what it's talking about when it says that when blood osmolarity decreases with low plasma sodium levels, it means the concentration of sodium is low, so you have a hypotonic environment. And so fluid will move from the extracellular space inside the cell, causing them to do what? Swell slightly. Excuse me. And it is this slight swelling that will inhibit ADH release. So you won't have this ADH release, so you're going to pee more. So it leads to less water reabsorption. In other words, instead of reabsorbing the water, you'll pee that extra water out. So you have more excretion of urine, bringing the ECF or the extracellular fluid space osmolarity up to normal. So you see that balancing act that is taking place. All right. So now the last one is the natriuretic peptide, a hormone that is secreted by special cells that line the atria of the heart. And it's called atrial natriuretic peptide, and also these cells that line the ventricles of the heart. You'll see this mostly in your heart failure patients whose the ventricle tissue is swells because of all that volume of fluid of blood that is backing up because the heart is failing. Now, the peptide secreted by the heart ventricular cells is known as brain natriuretic peptide, or BNP. And this is actually a lab that tells us if a patient is in active heart failure, because all that volume in the ventricles are stretching the ventricles, and so it will cause secretion of this particular hormone or peptide, a hormone. All right, and so the reason this is important is because these peptides are secreted in response, again, to increasing blood volume and blood pressure, which again will stretch the heart tissue. Kidney reabsorption of sodium then is going to be inhibited at the same time that urine output is going to be increased. So not only will the kidneys not reabsorb sodium, but it won't reabsorb water as well, and then it causes patients to diurese or lose fluids. And so as you lose more sodium and fluid volume through urine, the outcome is decreased circulating blood volume as well as a decrease in blood osmolarity. Right, so it'll bring the osmolarity down to hopefully more normal levels. But always remember that BNP, because it's a very important lab that we draw on our heart failure patients. All right. So the renin-angiotensin 2 pathway is a bit of a doozy for discussion, but I can get you through. But you have to really remember this particular compensatory mechanism because it is what causes vasoconstriction, and it also causes an increase in sodium and water reabsorption. All right, because it increases the amount of volume and sodium in our blood, our vascular system rather, causing an increase in our blood pressure. Typically, we find the renin-angiotensin-aldosterone system at play as a compensatory mechanism in heart failure. Because in heart failure, the heart is failing as a pump, and if it can't pump blood effectively throughout the systemic circulation, then our vital organs and tissues will begin to starve for lack of these nutrients and oxygenated blood and so forth. And so the kidneys will typically sense that, well, maybe the blood pressure is low, and meaning I can't get any perfusion in that case. and or maybe the blood volume is low. So this particular mechanism will kick in order to increase the blood plasma volume, as well as cause vasoconstriction of the arteries, which will increase the blood pressure. So this is what this particular um, compensatory mechanism does. All right. So now, the most important body fluids to keep in balance for optimal function are the blood volume or plasma volume and the fluid inside the cells or the intracellular fluid. Very important to keep a balance. Maintaining blood volume at a sufficient level for blood pressure, because when your volume is significantly lower in the vascular system, your blood pressure is also low. And the reverse is also true. If there's an increase in volume in the vascular system, your blood pressure is high. So maintaining volume at a sufficient level for blood pressure to remain high enough to ensure adequate perfusion is critical for life. So when you have a certain blood pressure, right, it has to be, blood pressure has to be a certain number, let's say 120/80, in order to maintain good perfusion to our vital organs and tissue. When that volume is low, when the blood pressure is low, it means our mean arterial pressure is low, and therefore we do not get perfusion, adequate perfusion to our organs and tissues. Now, a major regulator of fluid balance is the renin-angiotensin 2 pathway. They call it different things, but it's known as the renin-angiotensin system, or RAS, or it can also be RAAS, which is the renin-angiotensin aldosterone system. All right, which is it's the same, pretty much the same thing. But it depends on, I guess, how the author wants to list it. Now, because low blood volume and low blood pressure can rapidly lead to death, the body has many compensatory mechanisms that guard against low plasma volume. And so it involves specific responses to changes to change how water and sodium are handled in order to maintain the blood pressure. And this is the mechanism that we will discuss. One of the reasons you want to know this about this mechanism, and you don't ever want to forget it, is that these patients receive, these heart failure patients are placed on a medication called an ACE inhibitor. And when you talk about that multi-step process of the renin-angiotensin aldosterone system, a system that causes vasoconstriction, which means you're increasing the blood pressure, and also causes sodium and water retention, which increases the plasma volume. Well, increasing blood pressure and increasing blood volume is not good for heart failure patients, because a sick heart in a heart failure patient cannot handle a higher blood pressure, higher blood volume. And we'll get more into all that next term. But just know that this compensatory mechanism is not good for a failing heart. Perhaps if somebody's in shock, yes, but with a failing heart, that failing heart has to take on that additional volume, and it has to pump against that increasing vasoconstriction. All right. Now, the kidney is a major, again, it is a major regulator of water and sodium balance in order to maintain the blood pressure and perfusion to all tissues and organs. The kidneys our kidneys have the ability, rather, to monitor blood pressure, to monitor blood volume, to monitor blood O2 levels and blood osmolarity. And this is related to sodium concentration. So the kidneys sense that when the kidneys sense that any one of these parameters are getting too low, they begin to secrete a substance called renin that sets into motion a group of hormonal and blood vessel responses in order to ensure that the blood pressure is raised back to normal. All right, so renin, angiotensin, aldosterone system. So when the kidney sense that something is wrong, renin is going to be produced. And remember, this whole process, this multi-step process, is going to cause vasoconstriction, which increases the blood pressure, which is supposed to improve perfusion, and it will also raise the sodium and water levels in the vascular space in order to increase the blood pressure back to normal. So you get better perfusion, supposedly. Now, the triggering event for renin secretion is any change in the blood, indicating that perfusion is at risk. So it's essentially sensing perfusion. If that perfusion is off, renin is going to be secreted. All right. Now, well, let me kind of back up. So in heart failure patients, you don't want this process to take place because it's too stressful for the heart. So we give these patients ACE inhibitors, which will prevent one of these steps in this multi-step ROS process. All right, it'll prevent one of these steps, and therefore you don't have vasoconstriction, and you don't have this sodium and water retention, which is good for heart failure patients. You don't want that. So just keep in mind, we won't delve too much into that, but that's what ACE inhibitors are good for in this regard, when in terms of this compensatory mechanism. It's not a bad system, but it's just no good for heart failure patients. Now, in this renin, angiotensin, aldosterone system, it doesn't kick in just for issues dealing with the heart, but there are other situations as well. And I'll give you an example. So low blood pressure is a triggering event because it reduces perfusion to tissues and organs. Anything that reduces blood volume, whether that is dehydration or hemorrhage, below a critical level always lowers the blood pressure. And it's going to also trigger the renin, angiotensin, aldosterone event. Now, low blood oxygen levels also trigger triggering events because too little oxygen in the blood it cannot supply the needed oxygen and tissues. Well, if the blood pressure is too low, then you won't get O2 to our organs and tissues, and they will die as a result. Now, a low blood sodium level also is a triggering event because sodium and water are closely linked. Where sodium goes, water follows. And anything that causes the blood to have too little sodium prevents water from staying in the blood. So this patient becomes more volume depleted. The result is low blood volume with a low blood pressure, which means poor tissue perfusion. And so this renin angiotensin process acts to prevent this from happening, or to correct it, if you will. So once the kidneys sense that perfusion is at risk, special cells in the kidney tubule begin to secrete renin into the blood. Now, renin then activates angiotensinogen. This is the multi-step process that I'm going to go through with you. So renin then activates the angiotensinogen. This activated angiotensinogen is angiotensin 1, which is activated by the enzyme angiotensin converting enzyme, or ACE. It is activated to its most active form, which is angiotensin 2. All right, so kind of backing up a little, remember I just said angiotensin converting enzyme, or ACE. Remember ACE inhibitor? So when we give these patients ACE inhibitors, this is where it stops this process from occurring, so you don't get the vasoconstriction. All right. Now, so Once angiotensin 2 is developed, angiotensin 2 starts several actions in order to increase blood volume and blood pressure. First, it constricts the arteries and veins throughout the body. This action increases peripheral resistance and it decreases the size of the vascular bed, so it increases the size of our blood vessels. This decrease in size of the blood vessels actually increases the blood pressure as a compensatory mechanism without adding more volume, blood volume. So in this case, you're decreasing the blood vessel space, and that will increase the blood volume without or the blood pressure without blood volume. Well, blood volume will eventually occur after aldosterone kicks in, but at this point, you're just narrowing the vascular system to increase the blood pressure because you want better perfusion. Now, angiotensin 2 also constricts the size of arterioles, which feed the kidney nephrons. Now, this action results in a lower glomerular filtration rate and leads to a huge reduction of urine output. So you're conserving volume by not allowing patients to urinate. This decreased urine output prevents further water loss, so more is retained in the blood in order to help increase the blood pressure. Now, angiotensin 2 also causes the adrenal glands to secrete this hormone aldosterone. All right, remember this is one of the hormones I discussed earlier. Aldosterone is nicknamed the water and sodium saving hormone because it causes our kidneys to reabsorb water and sodium, right? And preventing them from being excreted in the urine. And what this does, this response allows more water and sodium to be returned to the general circulation or to the blood. And when that happens, now you got more blood volume. This will increase our blood pressure as well as our blood volume, and thereby increase or result in hopefully better perfusion. All right, and that's the renin-angiotensin aldosterone mechanism. It's a compensatory mechanism due to different conditions: low oxygen, low blood pressure, low volume, blood volume, and so forth. It is a system you want to remember forever. I cannot emphasize or stress that enough. All right, and so you got a good education on that, and so you should never forget it. All right, and here's what I was saying as far as the clinical application here, the ACE inhibitor. So the renin-angiotensin 2 pathway is stimulated whenever the patient is in shock, for example, because you know you're not getting adequate perfusion during shock. This is why urine output is used as an indicator of perfusion adequacy after surgery or anytime a patient has to undergo an invasive procedure or if they are at risk for hemorrhage. We always want to look at the urine output for these patients. If that urine output is decreased, it's because the kidneys are probably not getting adequate perfusion. All right. Now, this pathway also is related to management of hypertension or high blood pressure. Patients who have hypertension are often asked to limit their sodium intake. The reason for this is that a high sodium intake raises the blood level of sodium, causing more water to be retained in the blood volume and therefore causing higher blood pressure, which is not good for our patients. Now, drug therapy for hypertension management may include diuretic drugs that increase the excretion of sodium, so less is present in the blood, resulting in a decreased blood volume. Another class of drugs often used to manage blood pressure is the ACE inhibitors. Remember I talked about that, all right? Now, these drugs, they disrupt that renin-angiotensin 2 pathway by reducing the amount of the angiotensin converting enzyme, or ACE, made, so less angiotensin 2 is going to be present. If you have less of that present, then you get more vasodilation instead of vasoconstriction. So with less angiotensin 2, as I mentioned, vasoconstriction is going to be less. You're going to have reduced peripheral resistance. You're going to have less aldosterone production and an increase in excretion of water and sodium in the urine when this drug is given. All these responses lead to decreased blood volume and blood pressure, which is what you want, especially in heart failure patients. Not so much in patients who are in shock and they're losing a lot of volume and so forth. This can be very helpful. This ROS system can be helpful. Now, another class of drugs used to manage hypertension is the angiotensin receptor blocker, or what we call ARBs. Now, these drugs disrupt the renin-angiotensin 2 pathway by blocking the receptors that bind with angiotensin 2, so the tissues cannot respond to it and the blood pressure is lowered. All right? Because if those receptors cannot respond to aldosterone, then sodium in water or retention is not going to take place. Now, the most recent class of drugs to manage hypertension by changing the renin-angiotensin 2 pathway is the direct renin inhibitors. Right? This is a new classification. Now, these drugs, they act early in that pathway I described, and it prevents the enzyme renin from changing angiotensinogen into angiotensin 1. So it works a whole lot earlier in that process. These drugs may be combined with ARBs in order to block the pathway in more than one place. So you got all these multi-step processes in the renin-angiotensin aldosterone pathway. And so these drugs are stopping these pathways or blocking it at some point. And of course, this causes a greater reduction in blood pressure, again, which is what we want. Sorry, I kind of, right. All right, so this is a fluid and electrolyte exemplar. We talk about dehydration. As you can see here in this picture, you see how they're pinching up the skin. If this patient is dehydrated, it will remain that way for a minute before going back to the normal configuration. We sometimes do this in the back of the hand. We do it in the chest, as you can see here, and also in the forehead. And this is how we determine if someone is dehydrated or not. Not a good test to do in your older patients, as we have discussed. Now, in dehydration, fluid intake or retention is less than what is needed to meet the body's fluid needs, resulting in a deficit of fluid volume, especially in the plasma volume. Now, it is a condition rather than a disease and can be caused by many factors. And so I want you to look at table 11.3 for those factors. And I did provide some examples here. For example, dehydration can be caused from hemorrhage, vomiting, diarrhea, ileostomy, long-term MPO status, patients who are MPO for a long time. Also diuretic therapy, impaired thirst. You know, if the brain is damaged in that area and it causes patients not to drink, so it can lead to dehydration. But look at the complete list by looking at table 11.3. As far as fluid overload, excessive fluid replacement, heart failure can lead to fluid overload, long-term corticosteroid therapy because these patients retain fluid with this drug. There's also SIADH, or syndrome of inappropriate antidiuretic hormone. And with this particular condition, these patients are retaining fluids because ADH is not working. All right, so they retain fluid. And also another example for fluid overload is water intoxication. Patients, they can't get rid of the water, so we call it water intoxication, too much water within our vascular compartment or space. So older adults are at high risk for developing dehydration because they have less total body water than younger adults. In addition, many older adults have decreased thirst sensation and may have difficulty with walking or other motor skills needed to obtain fluids. So we have to think about this with our older adults. They also may be taking certain drugs such as diuretics, antihypertensives, and laxatives that increase fluid excretion. So we have to watch these patients as well. And this is why this is important interview information when you're having these discussions with these patients when they come to your facility or you go to their homes. Now, dehydration may occur with just water or fluid loss, or with water and electrolyte loss, which is what we call isotonic dehydration. Now, isotonic dehydration is the most common type of fluid loss problem. Now, fluid is lost only from the extracellular space, including both the plasma and the interstitial spaces. So this doesn't involve the intracellular space. There is no shift of fluids between spaces, so the intracellular fluid volume remains fairly normal. Now, circulating blood volume is decreased, and this is what we call hypovolemia, and it leads to reduced perfusion. All right. Now, the body's defenses, it compensates during dehydration in order to maintain perfusion to our vital organs in spite of hypovolemia. So our body has a way of fighting against that or compensating against that. Now, the main defense is by increasing vasoconstriction. Vasoconstriction, in other words, causes the blood vessels to constrict, and also peripheral resistance to maintain blood pressure and circulation. So that's how the body works in defense of dehydration or to defend against it. As far as health promotion and maintenance, mild dehydration is very common amongst healthy adults. And it is corrected or prevented easily by matching fluid intake with fluid output. So whatever you excrete, you take in, right? So we have to teach all adults to drink more fluids, especially water. Whenever they engage in heavy or prolonged physical activity, or if they live in dry climates or at higher altitudes. Now, beverages with caffeine can increase fluid loss, as can drinks containing alcohol. Therefore, these beverages should not be used to prevent or treat dehydration. And these are things, again, that we have to teach our patients about. Now, when we think about a history, when we're taking a history from our patients, we want to ask specific questions about food and liquid intake. Also, we assess the types of fluids and foods ingested to determine the amount and osmolarity of the blood. Many patients do not know that solid foods do also contain liquids, and they do. Other foods such as ice cream, gelatin, and ices are liquids at body temperature and are also included in calculating fluid intake. We also collect specific information about exact intake and output volumes and obtain serial daily weight measurements as well. If possible, weigh the patient directly rather than asking what he or she weighs, right? Weight loss is also an indication of dehydration because the more fluid you lose, your weight goes down. Now, because one liter of water weighs 2.2 pounds or 1 kilogram, changes in daily weights are the best indicators of fluid losses or gains. Right. So in other words, if a patient gains, if they take on another liter of water, they'll go up by 2.2 pounds or 1 kilogram, another kilogram. We want to also ask specific questions about prescribed or over-the-counter drugs, because older adults may use diuretics or laxatives that can lead to impaired fluid and electrolyte imbalance. We also want to ask about the presence of kidney or endocrine disorders. These can also impact fluid status and electrolytes. We want to assess the level of consciousness and mental status, because changes in mental status occur with fluid imbalance. We also ask the patient about changes in ring or shoe tightness. If you're wearing a ring and it becomes tight, the patient might be, or if the shoes become tight, the patient may be experiencing some fluid issue. Now, a sudden decrease in tightness may indicate dehydration, of course, but tightness can indicate volume access. Now, nearly all body systems are affected by dehydration to some degree. The most obvious changes occur in the cardiovascular and the integumentary system. Now, cardiovascular changes are good indicators of hydration status because of the relationship between plasma fluid volume, blood pressure, as well as perfusion. All right. The heart rate increases to help the blood pressure with less blood volume. So when a patient is dehydrated, you'll see an increase in heart rate because the heart rate is trying to help maintain the blood pressure. Peripheral pulses are weak, they're difficult to find and easily blocked. Blood pressure also decreases, as does pulse pressure, with a greater decrease in the diastolic blood pressure. Hypotension is more severe with the patient in the standing position than in a sitting or lying position. And we call this, because sometimes your doctors may want to get a blood pressure in the lying, sitting, and standing position, we call it orthostatic or postural hypotension, right? We want to also measure blood pressure first with the patient lying down, then sitting, then finally standing. And these measures are also called ortho checks or ortho changes. As the blood pressure decreases when changing positions, perfusion to the brain also decreases, causing lightheadedness and dizziness. So these patients become at risk for falling. And so we have to be careful, maybe have someone to assist in this effort. All right. Now, neck veins are normally distended when a patient is in the supine position, and hand veins are also distended when lower than the level of the heart. However, with dehydration, the neck and hand veins are flat. Even when the neck and hands are not raised above the level of the heart, they would be flat. That's an indication of dehydration. Now, respiratory changes include an increased rate because of the decreased blood volume reduces perfusion and gas exchange. So that's why you'll see a change in the respiratory system. Skin changes can indicate dehydration as well. Assess the skin and mucous membrane for color, for moisture, and also turgor. Assess skin turgor by checking how easily the skin over the back of the hand and arm can be gently pinched between the thumb and forefinger to form a tent, as you see in this picture. So how soon the pinch skin resumes its normal position after release is important, because the slower it is, it could be an indication of dehydration. So in dehydration, the skin turgor is poor, so with the tenting remaining for minutes after pinching the skin. The skin also looks dry and scaly. I also like for you to take a look at, well, actually I showed you this already. Take a look at figure 11.8, and it will show you how to perform a skin turgor test, which is what you're looking at. Now, in dehydration, oral mucous membranes may be dry, covered with a thick, sticky coating, and may have cracks and fissures. The tongue surface may also have deep furrows as well. All right. Now, neurological changes with dehydration include changes in mental status and temperature with reduced perfusion in the brain. Changes in cognition are more common amongst older adults and may be the first indication of fluid imbalance. So take a look at how these patients are acting. The patient with dehydration often has a low-grade fever, and the fever can also cause dehydration as well, because the metabolism is really burning, and so these patients can be at greater risk of dehydration. Now, kidney changes in dehydration affect urine volume and also concentration. So we want to monitor the urine output, comparing the total output with total fluid intake, as well as daily weights. Now, the urine may be concentrated with a urine-specific gravity of greater than 1.030. All right. So the normal range, I believe, is 1.005 to 1.030. The closer it is to 1.030, the more concentrated, and the closer to 1.005, the more dilute the urine is. All right. Now, if it's concentrated, these patients will have dark amber colored urine and a strong odor. All right. Now, urine output below 500 mLs per day for a patient without kidney disease is cause for concern. So use daily weights to assess fluid loss, and weight loss over a half pound per day is fluid loss is not good. Wow, that was a lot. Right. So remember, I told you 1 liter of water weighs 2.2 pounds, equal to 1 kilogram. So if a patient, or I should say, if their weight goes up, let's say from 55 to 56 kilogram, then you can essentially say there's 1 liter of fluid retention. And also weight change of 1 pound equals fluid volume change of about 500 mLs, whether that's up or down. All right. Now we're going to look at the assessment, a physical assessment, patient safety, pulmonary edema, drug therapy, nutrition, and also monitoring intake and output. So patients with fluid volume overload often have pitting edema. And so take a look at figure 11.11 for a demonstration of that, or an example of that. Other symptoms are usually seen in the cardiovascular, respiratory, and neuromuscular, integumentary, and also GI system. And you can take a look at that information in chart 11-4. Particularly, we see signs and symptoms of fluid overload by systems. So for example, cardiovascular changes. What we will see is an increase in pulse rate, These patients will have bounding pulse quality. They'll have elevated blood pressure, distended neck and hand veins, and also weight gain, etc. So take a look at that chart for additional information. Fluid overload is diagnosed based on assessment findings and the results of laboratory tests. Usually, serum electrolyte values are normal, but a decrease in hemoglobin, hematocrit, and serum protein levels may result from excessive water in the vascular space. And so we would call that a hemodilution. You got more solvent or blood to solutes, it is going to be a hemodilution. All right. Now, how do we respond to these issues? So the focus of priority nursing intervention is to ensure patient safety. We want to restore normal fluid balance, provide supportive care until the imbalance is corrected. And we also want to prevent future fluid overload. Drug therapy, nutrition therapy, and monitoring are the basic interventions for the nurse. Now, patient safety is the first priority. Interventions are implemented to prevent fluid overload from becoming worse, which can lead to pulmonary edema, heart failure, and complications of electrolyte dilution. Older adults or those with cardiac problems, kidney problems, and pulmonary problems, or liver problems are at greater risk. So we have to really watch these patients. We want to assess the patient with fluid overload at least every 2 hours to recognize pulmonary edema, which can occur very quickly and can lead to death. If indications of worsening fluid overload are present, you will see bounding pulse, increasing neck vein distension, or increased JVD is what we also call it. Presence of crackles in the lungs, increasing peripheral edema, reduced urine output as well. And we must notify the healthcare provider when this occurs. Now, the patient with fluid overload and edema is at risk for skin breakdown as well. So we want to use a pressure reducing or pressure relieving overlay on the mattress to reduce that from happening. We want to assess skin pressure areas, over those bony prominences daily for signs of redness or open area, especially the coccyx, the elbows, hips, and the heels. Now, because many patients with fluid overload may be receiving oxygen by mask or nasal cannula, we want to check the skin integrity around the mask, around the nares and ears, and under the elastic band, because these structures, these devices can put pressure on these areas, causing skin breakdown. So we want to look at them. All right. Help the patient change positions at least every 2 hours, or also ensure that the unlicensed assistant personnel can perform this action. This is where delegation comes into play. There's some things that they can do safely, but you have to make sure your UAPs can perform the different interventions in your institution. Now, drug therapy focuses on removing excessive amounts of fluid. So diuretics are used for fluid overload if kidney function is normal. You don't want to give diuretics to someone whose kidneys are in, let's say, the 5th stage, all right, because it won't work. And it can build up to toxic levels. Now, drugs may include high-ceiling loop diuretics such as furosemide or Lasix. If there is concern that too much sodium and other electrolytes will be lost during loop diuretics, then of course we have to replace them. We do want to monitor the patient's response to drug therapy, especially their weight loss and also increased urine output. This is something that we are assessing. Observe for indications of electrolyte imbalance. We're looking at those labs, especially changes in an electrocardiogram or ECG. So we want to monitor these patients on a cardiac monitor. We also want to assess for sodium and potassium values every 8 hours or whenever they are drawn. As far as nutrition therapy for the patient with chronic fluid overload may involve fluid restrictions of both sodium, of sodium and fluids actually. Often sodium restriction involves only no added salt to ordinary table foods when fluid overload is mild. For more severe fluid overload, the patient may be restricted to about 2 grams per day to about 4 grams a day of sodium. We want to teach the patient and family how to check food labels for sodium content, how to keep a daily record of sodium ingested, and also explain to the patient and family the reason for any fluid restriction and the importance of it adhering to the restriction. So this is a part of that health promotion and maintenance process that nurses must know for NCLEX as well. HESI also, and my exams. So monitoring intake and output and weight provides information on therapy effectiveness. So if the therapy is working well, then we know that we're doing good. We want to teach our UAPs or unlicensed assistant personnel that these measurements need to be accurate, not just estimated. Because treatment decisions are based on these findings. I mean, if someone is not excreting enough urine, we may have to increase the Lasix dose. We want to schedule fluid offerings throughout the 24-hour period. We give most fluids during the day and less towards the nighttime or evening, because you don't want patients up and down from bed having to use the bathroom. We also want to teach UAPs to check urine for color and characteristic, and they should report these findings to you. If a patient is receiving IV therapy, infuse the exact amount prescribed and no more, no less. All right. As far as fluid retention, fluid retention may not be visible. So rapid weight gain is the best indicator of fluid retention and overload. So we want to weigh these patients, and this will tell us if they are gaining weight. We want to weigh the patient at the same time every day, before breakfast, preferably using the same scale. Have the patient wear the same type of clothing for each weigh-in. When in bed, weights are taken, we want to lift additional tubing and equipment off the bed so we won't have an inaccurate measurement. We want to record the number of blankets and pillows on the bed at the initial weigh-in, and then ensure that ongoing weights always include the same number. All right, again, we want accuracy. Now, if a patient is discharged home before the fluid overload has completely resolved or has continuing risk for fluid overload, teach the patient and the family to monitor the weight at home. Teach them to keep a record of daily weights to show the healthcare provider at checkups when they have follow-ups. Instruct the patient to call the healthcare team for more than 3 pounds of weight gain in a week, or more than a 2-pound gain in 24 hours. Very important teaching for your patients, and also possibly for tests. And now we turn our attention to electrolyte imbalance. It can occur in healthy people as a result of changes in intake and output. And also it can certainly be life-threatening if severe enough, and it can occur anywhere, in any setting. Now, electrolytes or ions are substances dissolved in body fluid that carry an electrical charge. We talked about that earlier. The cation have a positive charge, as you see in K+ or potassium, and the anion has or have a negative charges such as chloride Cl minus. Body fluids are electrically neutral. They're neither one, which means that the number of positive ions is balanced by an equal number of negative ions. Now, most ions have different concentrations in the ECF and ICF fluid. This concentration difference, it helps maintain membrane excitability and allows nerve impulse transmission. And so that's why you need this, this difference. It helps with nerve impulse transmission. Now, the normal range of blood electrolytes are pretty narrow. So even small changes of these levels can cause some major issues for your patients. Now, electrolyte imbalances can occur in healthy people as a result of changes in fluid intake and output. Now, these imbalances are usually mild and are easily corrected. Now, severe electrolyte imbalances with actual losses or retention of electrolytes are life-threatening and can occur whether it be in the hospital, in the community, home, or whatever. It can be very dangerous. Adults at greater risk for severe imbalances are of course, older adults, which you would take care of mostly in your acute or subacute settings. Patients also with chronic kidney or endocrine disorders, and those who are taking drugs that alter fluid and electrolyte balance are at risk. All ill or sick adults are at risk for electrolyte imbalances, so we must watch our labs. Take a look also at table 11.1. List the normal serum levels of the major electrolytes, and chart 11.1 lists the normal electrolyte values for older adults. So I think I may have referred you to that before. Most electrolytes enter the body in ingested foods. So this is why we must encourage our patients to eat or know about their nutritional intake. Electrolyte balance occurs when dietary intake of electrolytes matches kidney electrolyte excretion and reabsorption. All right, so it has to match it. So in order to maintain that balance. So for example, serum potassium level is maintained between 3.5 and 5.0 milliequivalents. The high potassium level in foods such as meat, citrus fruit could increase the extracellular fluid potassium level and lead to major problems. Now, in health, kidney excretion of potassium keeps pace with potassium intake and prevents major changes in blood potassium levels. So as long as the intake matches the output, then these patients should be fine. Dehydration is dehydration as a result of excess fluid loss or inadequate intake can be an issue, and potential for injury as a result of blood pressure changes. Well, this is kind of more of a nursing diagnosis. Potential for injury as a result of blood pressure changes and muscle weakness. So we must observe these patients for safety. And these are some priority problems to observe: restoring fluid balance, which means we are fluid replacement. There's also drug therapy, and again, preventing injury. So as we look at the different electrolytes, sodium level is normally 136 to 145. Remember, wherever sodium goes, water will follow. We will talk about hyponatremia, meaning low sodium, and also hypernatremia, high sodium levels. Now, sodium is the major cation. Remember, it has that plus, that positively charged particle, which is located in the extracellular fluid, and it maintains ECF osmolarity. All right. And of course, the sodium levels in the extracellular fluid, that's when we talk about the 136 to 145. But there is some sodium in the intracellular fluid, and those levels are low. They're at 14 milliequivalents. Now, keeping this difference in sodium levels is vital for muscle contraction, cardiac contraction, and nerve impulse problems. So just know that whenever you see this a significant shift in sodium levels, then we know that the heart, the cardiac, the muscles, the cardiac, and the nervous system is impacted. Sodium levels and movement influences water balance because, again, wherever sodium goes, water goes as well. The ECF sodium level determines whether water is retained, excreted, or moved from one fluid space to another. Now, sodium enters the body through the ingestion of many fluids and many foods and fluids. Foods with the highest sodium levels are those that are processed or preserved, such as smoked or pickled foods, snack foods, and many condiments as well. Now, foods and sodium foods lowest in sodium include fresh fish and poultry, and most fresh vegetables and fruits. Now, low serum sodium levels inhibit the secretion of ADH and the uretic peptide, and also it triggers aldosterone secretion. And together, these compensatory actions can increase the serum sodium levels by increasing kidney reabsorption of sodium, and also enhancing kidney loss of water. Now, high serum sodium levels inhibit aldosterone, because you don't need the sodium now, secretion, and stimulate secretion of ADH, and also the natriuretic peptide hormone. So in other words, if you have high sodium levels, then aldosterone would not kick in. ADH will, because you want to obtain more fluids in an attempt to dilute the blood. Now, as far as hyponatremia, is an electrolyte imbalance in which serum sodium levels is below 136. The problems caused by hyponatremia occur from two changes. There's reduced excitable membrane depolarization, and also there is cellular swelling. Because when the extracellular fluid is low in sodium, then this hypotonic solution will move inside the cell, causing swelling. And then the nerve impulses will be impaired as well. Now, excitable cell membrane depolarization depend on high extracellular fluid levels of sodium being available to cross the cell membrane and move into the cells in response to a stimulus, right? This is how we get a stimulus, a movement of, let's say, muscles and whatnot. And so hyponatremia makes depolarization slower, so that excitable membranes are less excitable. So you get less movement, less stimulus when you have a low sodium. And you see some of these signs and symptoms as you look at some of the charts or tables. Now, with hyponatremia, the osmolarity of the extracellular fluid is lower than that of the intracellular fluid. And as a result, water moves into the cell and it causes it to do what? To swell. So when a patient has low sodium level, let's say maybe a 120 or something like that, it's said to be hypotonic. And so it moves from the extracellular to the intracellular. And remember, I showed you the picture. The fluids, the cells will swell. Now, even a small amount of swelling can reduce the cell function. And that's the danger of fluids moving inside the cell. When fluids move inside the intracellular space, causes it to swell, and all that pressure within that cell can impact the function of that cell. Now, larger amounts of swelling can make the cell lyse or burst and die. So you have to be careful about the amount of fluid that enters into the cell. You don't want to hang the wrong IV fluids. You don't want to hang, for example, in a situation like this, you do not want to hang, let's say, a half normal saline or the 0.45% saline, because the fluid is already hypotonic. And so you're just adding more fluids that will enter into the cell and cause it to burst. All right. So many conditions and drugs can lead to hyponatremia. And so take a look at table 11.5 for those conditions. A common cause of low sodium levels is the prolonged use and overuse of diuretics, especially in older adults. Loss of sodium loss, as well as water. When these drugs are used to manage fluid overload, sodium is lost along with water. Now, hyponatremia can result from the loss of total body sodium, the movement of sodium from the blood to other fluid spaces, or dilution of sodium, of serum sodium from excessive water in the plasma. Now, actual sodium deficits or causes can be from excessive diaphoresis, wound drainage, such as GI, also decreased secretion of aldosterone, because you know the aldosterone is the salt hormone, and also low sodium diets can also lead to a sodium deficit as well. So we need to look at these problems with your patients. When you see a patient with a wound drainage, just know that this patient can suffer from a sodium loss. So again, you're always looking at those labs. All right. Now, the signs and symptoms of hyponatremia are caused by its effects on excitable cellular activity. So the cells especially are affected are those involved in cerebral, neuromuscular, and intestinal smooth muscle, and also cardiovascular function. As far as cerebral changes are the most obvious problem of hyponatremia. Behavioral changes result from cerebral edema and increased intracranial pressure. So we want to closely observe and document the patient's behavior, their level of consciousness, and their cognition. Can they think? When sodium levels become very low, these patients can suffer seizures, coma, and also death. So the fact that you know they can suffer seizures, we want to put them on seizure precautions as well. As far as neuromuscular changes are seen as generalized weakness. So we assess the patient's neuromuscular status during each nursing shift for changes from the baseline. Deep tendon reflexes are also diminished. Muscle weakness is worse in the legs and also the arms. And so these patients are at risk for falling and injuring themselves. Intestinal changes include increased motility. There's which will cause nausea, diarrhea, and abdominal cramping. We want to assess the GI system by listening to bowel sounds and observing stools. All right, this is the job of the nurse. Bowel sounds are typically hyperactive, and bowel movements are rather frequent and also watery. All right. As far as cardiovascular changes are seen as changes in cardiac output. The cardiac response to hyponatremia with hypovolemia, meaning a decreased plasma volume, includes a rapid, weak, thready pulse, Peripheral pulses are difficult to palpate, and they can also be blocked. Blood pressure is going to be low, and the patient may have severe orthostatic hypotension, which can lead to lightheadedness and also dizziness. When hyponatremia occurs with hypervolemia, meaning fluid volume excess, cardiac changes include a full bounding pulse with normal to high blood pressure. These are the physiological changes that you'll see when there's too much volume with low sodium. Peripheral pulses are full and difficult to block. However, they may not be palpable if edema is present. Now, the cause of low sodium level is determined in order to plan the appropriate management. So we have to know what the cause is in order to treat it. Interventions with drug therapy and nutrition therapy are used to restore sodium levels to normal, prevent complications from fluid overload, and or too rapid change in serum sodium levels. The priorities for nursing care of the patient with hyponatremia are monitoring the patient's response to therapy and preventing hypernatremia and fluid overload. You know, if you're trying to correct the hyponatremia, sometimes too much of a treatment can result in the other extreme. For example, if you give a patient who has hyponatremia 3% normal saline, if you don't watch these patients closely and run that IV fluid at the right rate, they can go into hypernatremia. So you have to watch your therapy. Now, drug therapy involves reducing the doses of any drugs that increase sodium loss, such as most diuretics. So you may have to decrease the dose of your diuretic. When hyponatremia occurs with a fluid deficit, IV saline infusions are prescribed to restore both sodium and fluid volume. All right. So we use, in this case, saline infusions rather, in order to restore. Now, severe hyponatremia may be treated with small volume infusions of a hypertonic saline solution. And again, most of the time I've seen 3% saline, but they also have 5% saline. But the 5% saline is extremely concentrated, and it can be used for extreme hyponatremia. So when you're really trying to get the numbers back to normal a little faster, then you want to go with a higher percentage. Now, these infusions are delivered using a controller to prevent accidental infusion increases in infusion rate. So we want to monitor these patients. Now, when hyponatremia occurs with fluid access, so when there's too much fluid on board and the patient has a lower sodium levels, drug therapy includes drugs that promote excretion of water rather than sodium, such as medication called Vaporsol or Samca. All right. Drug therapy for hyponatremia caused by inappropriate secretion of the antidiuretic hormone, or SIDH, may include lithium, can also include a medication called declomycin. And so with these medications, we want to assess hourly for signs of excessive fluid loss, potassium loss, and increased sodium levels as well. Right. This is just a way that we monitor our therapies. Now, nutrition therapy can help restore sodium balance in mild hyponatremia. Therapy involves increasing oral sodium intake and restricting oral fluid intake. So you restrict oral fluid intake but you increase sodium intake, and that should get you back to the normal range. Now, fluid restriction may be needed long term when fluid overload is the cause of the hyponatremia or when kidney fluid excretion is impaired. So you may need fluid restriction in this regard. Now, hypernatremia or high sodium levels is when serum sodium levels are greater than 145 milliequivalents. It can be caused by or can cause changes in the fluid volume. Take a look at table 11.6 for the list of causes for hypernatremia. Common causes for hypernatremia. When will these patients have high sodium levels? You can see it in hyperaldosteronism, kind of hard to pronounce, especially this late at night. So when the hyperfunction of the of aldosterone, or when there's a whole lot of aldosterone being secreted, if you will. Corticosteroid therapy, Cushing's syndrome or disease, excessive administration of sodium-containing IV fluids as well can lead to hypernatremia. As serum sodium level rises, a larger difference in sodium levels occur between the ECF and the ICF. This can actually cause the cells to shrink because of that hypertonic environment. More sodium is present to move rapidly across cell membrane during depolarization, making excitable tissues more easily excited. And so it can lead to irritability. And this is when you have more sodium, hypernatremia. The membranes become more excited, but you don't want either. You don't want them to be less excited or more. You want them to be appropriate stimulation. Now, water moves from the cells, in this case, and into the extracellular fluid in order to dilute that hypertonic extracellular fluid. Because remember, with high sodium levels, the fluid environment is more hypertonic. And so fluid from the cells are going to move from the intracellular to the extracellular in order to try to dilute it. When serum sodium levels are high, severe cellular dehydration with cellular shrinkage occurs. So remember the picture I showed you, fluids will leave the cells, causing them to shrink and become more dehydrated. As far as assessment is concerned, symptoms of hypernatremia vary with severity of sodium imbalance and whether a fluid imbalance is also present. Now, changes are first seen in excitable membrane activity, especially the nerves, the skeletal muscle, and cardiac function. So these are the systems that we will be looking at for these abnormalities mainly. As far as nervous system changes, starts with altered cerebral function. So we want to assess these patients for mental status, for attention span, and also cognitive function as well. As far as its impact on skeletal muscle, we see skeletal muscle changes that vary with the degree of sodium increases. There's mild rises. Mild rises cause muscle twitching, remember, because it's more excitable, irregular muscle contractions. As hypernatremia worsens, the muscles and nerves are less able to respond to a stimulus, and muscles become progressively weaker. And so we want to assess muscle strength by having the patient perform hand grip and arm flexion against resistance. So you want them to try to flex, and you try to hold their hand from flexing to attest their strength. As far as cardiovascular changes, it includes decreased contractility because high sodium levels slow the movement of calcium into the heart cells. We want to measure the blood pressure, the heart, the rate, and quality of the apical and peripheral pulses. Pulse rate is increased in patients with hypernatremia and hypovolemia. Hypotension and severe orthostatic hypotension are present in these cases as well, because these patients are essentially dehydrated because they have so much sodium. There'll be neck veins or neck veins are distended, even with the patient in the upright position. And because you're pulling all that fluid from everywhere else, you have this extra volume in the ECF or extra cellular space. As far as interventions are concerned, drug and nutrition therapies are used to prevent further sodium increases and to decrease high serum sodium levels. Now, nursing care priorities for the patient with hypernatremia include monitoring the patient's response to therapy, ensuring patient safety by preventing hyponatremia and dehydration. Now, drug therapy is used to restore fluid balance when hypernatremia is caused by fluid loss. And so we will give these patients an isotonic saline or 9% saline, and also dextrose 5% in half sodium chloride are often prescribed. Now, although the dextrose in 45% sodium chloride is hypertonic in the IV bag, and this is very important for you to know. Once it is infused, once that dextrose in half normal saline is infused as a hypertonic solution, the glucose, that dextrose, in other words, is going to be rapidly metabolized. And then that fluid is really going to be hypotonic in that case. So you want to be careful about prescribing this, or not prescribing, but administering this particular IV fluid. I would be more inclined to infusing the normal saline because it doesn't have, it is a true isotonic solution, and it will remain an isotonic solution. It will not become hypotonic because it doesn't have dextrose. Now, hypernatremia is caused by reduced kidney sodium excretion, or let me change that. So hypernatremia that is caused by reduced kidney sodium excretion requires drug therapy with diuretics that promote sodium loss, such as furosemide or Lasix. Or also Bumex, which is also a loop diuretic, can be used. Both Lasix and Bumex are what we call loop diuretics, meaning they're powerful diuretics. It causes excessive amounts of sodium and water loss of the electrolytes. We want to assess the patient hourly for symptoms of excessive losses of fluid and sodium or potassium. The next electrolyte is potassium. The normal range is 3.5 to 5.0. All right. Some control over intracellular osmolarity and volume. It has some control, potassium. Potassium is needed for protein synthesis, glucose use, and also storage. And of course, we will be talking about hypokalemia or low calcium, low potassium levels, and also hyperkalemia or high potassium levels. Now, potassium is the major cation of the intracellular cellular fluid. So you mostly find potassium inside the cell. The normal plasma level ranges from 3.5 to 5.0. And so you can take a look at table 11.1 for that information. Now, the normal intracellular fluid potassium level is about 140 milliequivalents. All right. Now, keeping this large difference in potassium concentration between the ICF and the ECF is critical for excitable tissues to depolarize and generate an actual action potential. It's how we get a stimulus, which is what your electrolytes are important for. All right. Now, because potassium levels in the blood and interstitial fluid are so low, any change can seriously affect the physiologic activities. All right. So, for example, a decrease in blood potassium of only 1 milliequivalent is a 25% difference in total ECF potassium concentration. So that can be pretty significant. All right. Remember, they're maintained in very narrow ranges. Now, almost all foods contain potassium. It is highest in our meat, fish, and many, but not all, vegetables, as well as fruits. And it is found, the lowest amount is found in eggs, bread, and cereal grains. Now, the main controller of extracellular potassium level is the sodium potassium pump within the membrane of all body cells. In other words, if sodium and potassium are going to switch places, it requires a sodium potassium pump. Now, this pump moves extra sodium from the intracellular fluid, and it moves extra potassium from the extracellular fluid back into the cell, because sometimes this is needed depending on our levels. In this way, the serum potassium level remains low and the cellular potassium remains high. At the same time, now this action also helps the serum sodium levels remain high and the cellular sodium levels to remain low. So it just depends on what the body needs at the time. About 80% of potassium is removed from the body by the kidney, and the kidney excretion of potassium is enhanced when aldosterone is at play. So when aldosterone is secreted, patients will hold on to sodium in water, but they'll excrete potassium. So these patients are at risk for hypokalemia. Again, we got to look at those labs. So the first condition we'll look at is hypokalemia, low potassium, because most potassium is inside the cells, as I mentioned. These minor changes in extracellular potassium levels can cause major changes in cell membrane excitability. Now, hypokalemia is a serum potassium level that is less than 3.5. Remember, that's the low end of that range. And it can be life-threatening because everybody's system is affected. It relies on potassium. Now, decreased serum potassium levels reduce the excitability of cells. All right, the cells can barely respond. The cell membranes of all excitable tissues, such as nerve, muscles, are less responsive to normal stimuli. All right. Now, a gradual potassium loss may have no symptoms until the loss becomes more extreme. A rapid reduction of serum sodium levels cause dramatic changes in function. So when it's dramatic, you'll see the change more readily. Also take a look at table 11.7. It lists causes of hypokalemia. Common causes of hypokalemia are diuretics, corticosteroids, diarrhea, vomiting, wound drainage, such as especially GI, and also prolonged nasogastric suction and nothing by mouth, or when patients are NPO. So assessment. When we think about assessment, age is important because urine concentrating ability decreases with age. Right, the kidneys cannot concentrate as well as we get older, which increases potassium loss in these patients. Older adults are more likely to use drugs that lead to potassium loss as well, especially like your Lasix. Now, drugs, especially diuretics, corticosteroids, beta adrenergic agonists, or antagonists can increase potassium loss through the kidneys. We want to ask these patients about prescriptions, any prescriptions they're taking, any over-the-counter drugs. Patients who are taking digoxin, when potassium increases or low potassium, it increases the sensitivity of the cardiac muscle to the drug and may result in dish toxicity. So low potassium and patients taking digoxin may result in dish toxicity, even when the digoxin level is within the therapeutic range. So we have to correct the potassium levels here. We want to ask these patients if they're taking a potassium supplement such as KCl, or if they're eating foods that are high, that have high concentrations of potassium, such as bananas, citrus juices, raisins, or meat. The patient may not be taking the supplement as prescribed because of its unpleasant taste. And so we have to ascertain this piece of information. Now, disease can lead to potassium loss as well. Ask about chronic disorders, recent illnesses, medical or surgical interventions, a thorough nutrition history, including a typical day's food and beverage intake, helps identify patients at risk for hypokalemia. Sorry about that. Now, respiratory changes occur because of respiratory muscle weakness, resulting in shallow respirations. So we want to assess the patient's breath sounds, ease of respiratory effort, color of the nail beds. We want to check their mucous membranes, the rate and depth of respirations. We also want to assess the respiratory status of a patient with hypokalemia at least every 2 hours, because respiratory insufficiency is a major cause of death in these patients. As far as musculoskeletal changes, they include skeletal muscle weakness. Patients may be too weak to stand. Hand grips or hand grasp are weak, and deep tendon reflexes are reduced, resulting in hyporeflexia. Severe hypokalemia causes flaccid paralysis. We also want to assess for muscle weakness and the patient's ability to perform their activities of daily living. As far as cardiovascular changes, are assessed by palpating the peripheral pulses. In hypokalemia, the pulse is usually thready and weak, so palpation can be difficult, and the pulse is easily blocked. We want to measure blood pressure with the patient in the lying, sitting, and standing position. because orthostatic hypotension occurs with low potassium. Neurologic changes from hypokalemia include altered mental status. The patient may have short-term irritability, anxiety followed by lethargy that progresses to acute confusion and coma as hypokalemia worsens. Now, there's also intestinal changes that occur with low potassium levels because the GI smooth muscle contractions are decreased with low potassium, which can lead to decreased peristalsis. All right, so these patients can become more constipated. Bowel sounds are hypoactive. These patients experience nausea, vomiting, again, constipation. Their abdomen can become distended, which is common. We want to measure their abdominal girth with a measurement device. We want to also auscultate or listen for bowel sounds in all four quadrants of the abdomen. And severe hypokalemia can cause the absence of peristalsis. And so these patients can develop what we call a paralytic ileus, meaning the intestines are not moving at all, and they're supposed to move. Laboratory data can confirm hypokalemia. The serum potassium value is going to be less than 3.5. Now, hypokalemia causes ECG changes in the heart. It can cause an ST segment depression, a flat or inverted T waves. For some of you who have not had dysrhythmia training yet, you probably won't recognize these, but if you look at an ECG tracing, some of those complexes are abnormal. There may also be increases in U waves, so don't worry about all this, but just know that there's ECG changes. So dysrhythmias can lead to death, particularly in older adults who are taking digoxin. As far as interventions are concerned, interventions for hypo or low potassium focuses on preventing potassium loss, increasing serum potassium levels, and also ensuring patient safety. Remember, these patients can become very weak. Drug and nutrition therapies help restore normal serum potassium levels. The priorities for nursing care of the patient with hypokalemia are ensuring adequate gas exchange, patient safety for fall prevention, prevention of injury from potassium administration. Remember, we never direct push potassium. It is in a bag to drip, and also monitoring the patient's response to therapy. Now, chart 11 and 5 highlights best practice activities when caring for a patient with low potassium. So take a look at that. Now, we want to give prescribed oral potassium supplements. It should be well diluted and with a meal or just after a meal or snack in order to prevent nausea and vomiting. The taste is not good. Prevent accidental overdose of IV potassium by checking and rechecking the concentration of potassium in the IV solution, ensuring that maximum concentration is no greater than 1 milliequivalent per 10 mLs of solution. And when we say double check, make sure when you're in a clinical setting that you check each other. Say, hey, I'm getting ready to hang this potassium. Can you double check it with me? Because this can kill, too much potassium can kill your patients. We want to establish an IV access in a large vein with a high volume of flow, avoiding the hand because potassium can be very irritating. We want to assess the IV access for placement and adequate blood return. We want to make sure it's actually in the vein before administering potassium-containing solutions. We want to also keep the patient on bed rest until hypokalemia resolves, or provide assistance when out of bed to prevent falls. We want to stop the infusion immediately if the patient reports pain or burning or any sign of infiltration at the site. And read the rest of the information about potassium administration as well. Very important. You will be giving this a lot. Now, drug therapy for management and prevention of hypokalemia includes additional potassium and drugs to prevent potassium loss. Most potassium supplements are potassium chloride, potassium gluconate, or potassium citrate. Usually we get potassium chloride though. Now, as a special note, potassium is given intravenously for severe hypokalemia. The drug is available in different concentrations, and it carries a high alert warning as a concentrated electrolyte solution. So you may have something pop up on your screen warning you that, giving you a high alert that be careful while you're administering this drug. Now, the Joint Commission's national patient safety goals, they mandate that concentrated potassium be diluted and added to IV solutions only in the pharmacy by a registered pharmacist, and that vials of, the little vials of concentrated potassium not be available in the patient care areas, so you don't inadvertently give it, by mistake. Now, before infusing any IV solution containing potassium chloride, check and recheck the dilution of the drug and the IV solution container. Very, very important that you pay attention to this piece. Now, potassium is a severe tissue irritant and is never given by IM or subcutaneous injection. It is always given either by mouth, if it's a pill, or by IV. Now, tissue damage by potassium can become necrotic, turns black. The tissue dies, causing loss of function and also requires surgery, in other words, like a debridement. Very dangerous. IV potassium solution can irritate the veins and also cause phlebitis. Check the prescription carefully to ensure that the patient receives the correct amount of potassium. We want to assess the IV site hourly and ask the patient whether he or she feels burning or pain at the site, because we might have to stop it. If infiltration of solution containing potassium occurs, we want to stop the IV solution immediately. Remove the venous access and notify the healthcare provider or a rapid response team. And we want to also document these actions along with a complete description of the IV site. And that's why you must be really diligent in checking your IV sites. Now, oral potassium preparations may be taken as a liquid or solid as well. Now, potassium has a strong, unpleasant taste that is difficult to mask, although it can be mixed with many liquids. We used to mix it with orange juice. Now, because potassium chloride can cause nausea and vomiting, give the drug during or after a meal, or advise the patients using the drug at home not to take it on an empty stomach. Really important information for you to know as well. This could even appear on your midterm HESI. Now, diuretics that increase the kidney excretion of potassium can cause hypokalemia, especially your loop diuretics and your such as Bumex and furosemide. And they also talk about thiazide diuretics, but not as much with thiazide diuretics. These drugs are avoided in patients who already have hypokalemia. Now, there's also a potassium sparing diuretic that may be prescribed to increase the urine output without increasing potassium loss. Now, potassium sparing diuretics include aldactone and also triaterin, as well as amiloride. These are your potassium sparing diuretics, which you have to be careful with these patients developing hyperkalemia. Now, nutrition therapy involves collaboration with a dietitian to teach the patient how to increase dietary potassium intake. So eating foods rich in potassium helps prevent further loss, but supplementation is needed to restore normal potassium levels. So the patient will be prescribed a supplement. We want to implement safety measures with a patient who has muscle weakness from hypokalemia, including fall precautions, which are listed in chart 3-4. Take a look at that. Be sure to have the patient wear a gait belt when ambulating with assistance. Now, respiratory monitoring is performed at least hourly for severe hypokalemia. Also check oxygen saturation by by pulse oximetry to determine breathing effectiveness. We want to assess respiratory muscle effectiveness by checking patient's ability to cough. We want to examine the face, the oral mucosa, and nail beds for pallor and cyanosis. We should evaluate arterial blood gas values when available for decreased oxygen, blood oxygen levels, known as hypoxemia, and also increase arterial carbon dioxide levels, which is called hypercapnia, which indicates inadequate gas exchange. Now, as far as hyperkalemia or high potassium, it is when the potassium level is greater than 5.0. Even small increases above normal values can affect excitable tissues, especially in the heart. So we want to place these patients on a cardiac monitor always. Don't ever forget that. Now, high serum potassium increases cell excitability, causing excitable tissues to respond to less intense stimuli. In other words, it wouldn't take too much stimuli to get a response when you have high potassium levels. Now, the heart is very sensitive to serum potassium increases. It does interfere, it interferes with the electrical conduction system, leading to what we call a heart block. And also it leads to ventricular fibrillation. This is when you see those squiggly lines on a ECG tracing, and the heart is essentially doing this. It's basically just quivering or fibrillating. So you're getting no cardiac output in that sense. Now, the problems that occur with hyperkalemia are related to how rapidly ECF fluid potassium levels increase. So the higher the ECF fluid or rather the potassium levels increase, the greater the problems. A sudden potassium rises causes severe problems at serum potassium levels of 6 and 7 milliequivalents. So if the levels rise as high as 6 to 7, you're going to see some pretty significant problems. Now, hyperkalemia is rare in people with normal kidney function. Those at greatest risk are chronically ill patients, debilitated patients, and older adults. And take a look at table 11.8 for those at greatest risk. Common causes of hyperkalemia: over ingestion of potassium containing foods or medications, salt substitutes. Be careful about the salt substitutes. Rapid infusion of potassium containing IV solution, potassium chloride, acidosis, uncontrolled diabetes mellitus, kidney failure, like CKD, chronic kidney disease, or acute kidney disease, and also potassium sparing diuretics and ACE inhibitors. All right. Remember, that's why it's called potassium sparing. You're getting rid of very little to perhaps no potassium. As far as assessment is concerned, age is important because kidney function decreases with age, with aging. Ask about kidney disease, diabetes, any recent medical or surgical treatment. Ask about the patient's urine output measurements, including frequency and amount of voidings. Ask about drug use, particularly potassium-sparing diuretics, because these can lead to an increase in potassium levels. Also, if they're on ACE inhibitors, we need to know that. These drugs increase potassium levels. We want to obtain a nutrition history to determine the intake of potassium-rich foods and the use of salt substitutes, which can contain potassium. Ask these patients if they've had or experienced heart palpitations, if they feel like their heart beat is skipping a beat, or other cardiac irregularities. Ask if they have muscle twitching of the leg, lower limb weakness or weakness in the extremities. We want to know if there's unusual tingling or numbness in the hands and feet and face. All can be indications of hyperkalemia. Ask about recent changes in bowel habits, especially diarrhea, because you can lose potassium in diarrhea as well. Now, the cardiovascular changes are the most severe problems from hyperkalemia and are the most common cause of death in patients with hyperkalemia. Cardiac signs and symptoms include sinus bradycardia, low blood pressure. You'll see ECG changes of tall, peaked T waves, prolonged PR intervals. These are just dealing with ECGs and how you measure them. So just know that there'll be some changes in ECGs. You possibly may find flat or absent P waves and YQRS complexes. Complete heart block can occur. Asystole, ventricular fibrillation are life-threatening complications from severe hyperkalemia. Now, neuromuscular changes with hyperkalemia have two phases. Skeletal muscles twitch in the early stages of hyperkalemia, and the patient may be aware of tingling and burning sensations, followed by numbness in the hands and the feet, and also around the mouth, and we call that paresthesia. Now, as the hyperkalemia worsens, muscle weakness occurs, followed by flaccid paralysis, and respiratory muscles are not affected until serum potassium levels reach a more lethal levels. Now, as far as intestinal changes, it includes increased motility with diarrhea. The faster your GI motility, then these patients mostly have diarrhea, watery stools. When GI motility is decreased, then these patients experience constipation. So you have these hyperactive bowel sounds. Bowel movements will be frequent and watery. As far as laboratory values, in terms of hyperkalemia, potassium levels are greater than 5.0. If it is caused by dehydration, levels of other electrolytes, hematocrit and hemoglobin are also elevated. So there's a hemo concentration, if you will. Hyperkalemia caused by kidney failure occurs with elevated serum creatinine. So you see the creatinine levels are elevated, the BUN is elevated. There would be a decrease in blood pH, in other words, acidosis. And normal or low hematocrit and hemoglobin levels are found as well. Now, as far as treatment is concerned, interventions for hyperkalemia focus on reducing the serum potassium level, preventing recurrences, and ensuring patient safety. And drug therapy is key here. The priorities for nursing care of the patient with hyperkalemia are assessing for cardiac problems, patient safety for fall prevention, monitoring the patient's response to therapy, and also health teaching. Now, drug therapy can restore potassium balance by enhancing potassium excretion and promoting the movement of potassium from the extracellular fluid and back into the cells, which we usually use insulin for that. A newly approved drug to treat hyperkalemia is called Veltessa. This oral drug binds with potassium in the GI tract and decreases its absorption. So that can lower the potassium level. We want to stop potassium containing infusions and keep the IV access open. We also want to withhold oral potassium supplements and also potassium or provide potassium restricted diet. So any food with too much potassium, we want to restrict. Increasing potassium excretion helps reduce hyperkalemia if the kidneys are functioning normally. So potassium excreting diuretics are prescribed, such as Bumex, torsemide, Lasix as well. When kidney problems exist, more invasive interventions may be needed, such as hemodialysis. All right. Now, sometimes we may want to move potassium from the extracellular fluid space back into the intracellular fluid space, which can help reduce the serum potassium levels temporarily. So potassium movement into the cells is enhanced by insulin. So when we give insulin, it causes potassium to move inside the cells. We do this with our DKA patients because they tend to have acidosis and increase in potassium levels as well. So we push the potassium back inside the cell, and patients have less cardiac issues. Because high potassium levels results in significant cardiac problems. Insulin increases the activity of the sodium-potassium pump, which move potassium from the ECF into the cell. Now, IV fluids containing glucose and insulin are prescribed to help to decrease serum potassium levels. Usually, you'll have 100 cc's of 10 to 20% of glucose with 10 to 20 units of regular insulin. All right. So this insulin, again, will help move the potassium inside the cell. Now, and the glucose will help or prevent patients from becoming hypoglycemic. Now, these IV solutions are considered hypertonic and are infused through a central line or in a vein with a high blood flow in order to avoid local vein inflammation, because a small vein just can't handle a hypertonic solution. So we do want to observe patients for indications of hypokalemia, because remember, as the insulin moves the potassium inside the cell, if this happens too much, the potassium levels in the extracellular space can be low. And also hypoglycemia can result from this therapy as well, which is why we put glucose in solution to help prevent that from occurring. Because remember, when you give that insulin, not only is glucose going inside the cell, potassium as well. So these patients can suffer hypokalemia as well as hypoglycemia, something we're trying to prevent. Cardiac monitoring allows for early recognition of dysrhythmias and other symptoms of hyperkalemia on cardiac muscle. Now, health teaching is key to prevention of hyperkalemia and the early detection of complications. So the teaching plan includes diet, drug, and recognition of the indicators of hyperkalemia. Also, foods that are low in potassium are listed. So take a look at chart 11.6. Instruct the patient and family to read the labels on drug and food packages to determine the potassium content. Food high in potassium, meats, especially organ meat and preserved meat, dairy products, etc. Take a look at that. Fruits high in potassium, bananas, kiwi, oranges, etc. Take a look at that as well. Vegetables high in potassium, such as avocados, broccoli, and potatoes, white or sweet, and spinach. Take a look at that as well. Fruits low in potassium, such as fresh, frozen, or canned. Apples, cranberries, grapefruit, and also pineapples, etc. So we want to look at that as well. And also see the rest of the foods that vary in potassium content. So that's quite a mouthful, actually. All right, and the next, I should stop right here, but well, I'm sort of kind of at the end, so I think I might keep going. If I stop, I might stop at phosphorus. It's not much with that one. So, but the next one is calcium, very important cation, having two positive charges. So you'll see Ca++ or Ca a superscript 2 plus, right? And it just means calcium. It has two cations, these ions exist in the body, and it is bound in its bound form, and also in ionized unbound or free form. So when you think about potassium, it can be bound to some other structure, and or such as protein, or it can be free. Bound calcium is usually attached to serum proteins, especially albumin. I just saw that. Ionized calcium is present in the blood and other extracellular fluid as free calcium. All right. Calcium in the intracellular fluid is very low. Now, your free calcium is the active form. It must be kept within a very narrow range in the extracellular fluid. And so take a look at table 11.1 for that information. It's a very narrow range. I want to say like 9 to 10 or something like that. Now, this mineral is important for maintaining bone strength and density, activating enzymes, allowing skeletal and cardiac muscle contraction, and controlling nerve impulse transmission and allowing blood clotting. So this is why this electrolyte is extremely important. Now, calcium enters the body by dietary intake usually, and absorption through the intestinal tract. That's how we get our calcium. Absorption of dietary calcium requires the active form of vitamin D. So without vitamin D, you can't absorb calcium. Calcium is also stored in our bones. When more calcium is needed, the parathyroid hormone, which we talk about in the endocrine disorders, is released from the parathyroid glands, and it causes calcium to be stripped away from our bones. Now, when excessive calcium is present in plasma, then the parathyroid hormone secretion is going to be inhibited because you don't need it. You don't need any more calcium. It's too much. And the secretion of thyrocalcitonin, a hormone secreted by the thyroid gland, is going to be increased. Now, this particular hormone causes plasma calcium levels to decrease by inhibiting bone resorption of calcium. So it won't take away calcium from the bones. It also inhibits vitamin D associated with intestinal uptake of calcium. And this thyrocalcitonin causes increasing kidney excretion of calcium in the urine. So this is how we maintain calcium levels. So we get help from the thyroid gland, in other words. As far as hypokalemia, hypokalemia is a total serum calcium level of less than 9 or 2.25 millimoles, so they kind of measure them a little differently here. Now, because the normal blood levels of calcium is so low, any change in calcium levels has major effects on function. Now, low serum calcium levels increase sodium movement across excitable membrane. So when the calcium levels are low, then sodium levels can move across the membrane very quickly. And this allows depolarization to occur more easily and at inappropriate times. And this is why we always want to correct our electrolytes because of things like this or problems like this that can occur. Now, hypocalcemia is caused by many chronic and acute conditions as well as medical and surgical treatments. Take a look at table 11.9 that lists causes of hypokalemia. Acute hypocalcemia results in the rapid onset of life-threatening symptoms. All right, and common causes of hypokalemia is inadequate oral intake of calcium. Some patients may have malabsorption syndromes, like they can't really absorb calcium in the GI tract, such as celiac sprue, Crohn's disease. There's also inadequate intake of vitamin D. Remember, vitamin D is necessary for calcium absorption. Some of these patients may have end-stage kidney disease, diarrhea, relative calcium deficits, such as can be seen in alkalosis. Remember, with alkalosis, you normally see hypocalcemia. Also seen in acute pancreatitis, also in those patients who are immobile. All right. And removal or destruction of the parathyroid gland. These are all causes of hypocalcemia. As far as assessment is concerned, we want to assess nutritional history for the risk of hypocalcemia. We want to ask a patient about his or her intake of dairy products, and whether they take calcium supplements regularly. So one indicator of hypocalcemia is a report of frequent and painful muscle spasms or Charlie horses in the calf or the foot during rest or sleep. So we want to ask about a history of recent orthopedic surgery or bone healing. We want to know if the patient has had thyroid surgery, because sometimes when you remove the thyroid gland, you may inadvertently remove the parathyroid gland as well, since they are very close together. There's also, I want to also ask if they have therapeutic irradiation of the upper, in other words, if they receive radiation to the upper chest, neck area, or recent anterior neck injury, because you can injure the parathyroid gland, and this can also increase the risk of hypocalcemia. Now, most symptoms of acute hypocalcemia are caused by overstimulation of the nerves and muscles. Now, neuromuscular changes often occur first in the hands and feet. Paresthesia occur at first with sensations of tingling and numbness. If hypocalcemia continues or worsens, muscle twitching or painful cramps and spasms can occur. Tingling may also affect the lips, nose, and ears. These problems may signal the onset of neuromuscular overstimulation or the condition we call tetany. You know, those severe spasms that I talked about yesterday, I believe. Or today, I think. No, yesterday. So I've already talked to you about when you assess for hypocalcemia by testing with the Trousseau and Chabot-Tech sign. So just go ahead and read this area again. I've talked about that already earlier. As far as cardiovascular changes involve heart rate and ECG changes. So the heart rate may be slower or slightly faster than normal with a weak and thready pulse. Severe hypocalcemia causes severe blood pressure, low blood pressure. There's ECG changes of a prolonged ST interval and a prolonged QT interval. In other words, a dysrhythmia, ECG. Now, one thing I want to mention real quickly, keep in mind, remember when we were talking about alkalosis and how hypocalcemia usually accompanies alkalosis? Well, these are the same symptoms because we're talking about hypocalcemia and the symptoms are pretty similar. So keep that in mind. When you read one, then you can pretty much figure out the other. You look at the symptoms for hypocalcemia and alkalosis, they're pretty similar. We also want to assess the abdomen for hyperactive bowel sounds. The patient may report painful abdominal cramping and diarrhea. Skeletal changes are common with chronic hypocalcemia. Calcium leaves bone storage sites. So calcium leaves the bone, and a loss of bone density results in osteoporosis. So the bones are less dense, they become brittle, they become fragile, and they can break very easily. Vertebrae become more compact and may bend forward, leading to overall loss of height. Ask about changes in height and any unexplained bone loss, bone pain rather. So we want to observe the spinal curvatures and any unusual bumps or protrusions in the bones that may indicate old fractures. Protrusions. I can barely say that. I'm so hungry. This is a pretty long lecture. So what I'm going to do from here, I want you to read the rest of this information. It's on slide 22. Let me highlight that in red, and I'll probably indicate that on here. So at this point, I won't go into each of the details, but I want you to look at the interventions for a low calcium. Then you will look at hypercalcemia, look at the normal range, or hypercalcemia is a level greater than 10.5. So just take a look at the hypercalcemia, look at the assessment data for hypercalcemia. Remember, we're looking at especially the cardiovascular changes. We're also looking at the neuromuscular system, intestinal changes. And then we want to look at the interventions for hypercalcemia. We sometimes give these patients diuretics to help pee out the extra calcium. So take a look at the interventions that are done. And all the monitoring that is supposed to take place with this condition as well. All right, just kind of speed this along. And you saw this picture, or I referred to this picture earlier. This is the Trousseau and Chevos-Tex sign. It indicates a patient who may have low potassium levels. Here, I want you to look at the phosphorus levels. Go ahead and read about it. Not as much information on this slide as compared to the other electrolytes or major electrolytes. So take a look at the the causes of the description, the causes, assessment, and interventions. Take a look at hyperphosphatemia. It provides a description, causes, assessment, as well as interventions. Also take a look at magnesium. It provides a description. I want you to look at hypomagnesemia, its causes, its effect on the cardiovascular, neuromuscular system, and the intestinal system. We want to look at the interventions. Also, we're taking a look at the high or hypermagnesemia. Look at the description, the ranges, its effect on the cardiac system, the central nervous system, the neuromuscular system. Look at the interventions as well. All right. And also look at chloride as well. There's not much information on this one at all. Actually, look at the levels. Usually chloride and sodium are hand in hand. Sodium chloride, they are hand in hand. They go hand in hand. And also look at the special considerations for older adults. All right, just take a look at this information as well. And that is it, folks. This could have went a whole lot longer, but I'm going to put that back on you guys to just read the rest of my presentation. It's not as much for you to see. And again, it is on, I want to say, it's on slide, it starts at slide 22. And what I'll say here is read from here. And I'll also say no voiceover, VO, no VO, no voiceover. So just take when you get to this portion, you know that I stopped talking about it in detail on voiceover and just read the rest of the slides. Same approach when you're looking at everything else. All right. So that was long, that was tedious, but thankfully we got through it. It's almost 1 o'clock. I think I started this at around 9. So just imagine me trying to cover all this in class. It's just impossible. So I'm going to stop this recording.